I'd like to thank organizing team and Khandaka sir to give me this opportunity of presenting on this useful topic. I think some of it might be repetition because Dr. Ashwani Mathur and Dr. Khandaka sir has already covered most of it. There is not much to talk about. But most importantly, I would like to thank the audience in the back who have persisted till this late to listen to us. Thank you so much. If I can have the... So let's start. So I'm not going to stay much on this slide. I think we all agree that the world is getting fatter, we are getting heavier as the day goes, and multiple publications and surveys will show that obesity is on the rise. And it can be on rise of multiple reasons, mostly due to sedentary lifestyle. Also, due to change in the food habit, a lot of us are eating a lot of junk. Coke and Pepsi are deep down into the villages, so nobody is far away from being obese. So I will not go on the figures. Now I'll try to keep my presentation very simplistic so that we can at least get away with some points, especially for the junior audience who are staying in the back. Now whenever you are trying to operate on a patient, especially in the theatre, receiving a normal patient, thin patient is very different to receiving an obese patient, and Khandaka sir has shown some beautiful images and has already stressed that these patients, a normal OT table can take up to around 150 kilos, and that I'm talking about a good operating table. Most of us use in Indian made OT table, and they will not be sufficient to hold the whole weight of the patient, especially if you're operating on the obese patient. So what option do we have? So either buy a good quality table which is meant for obese, or at least put 2 OT tables on side, each side to side, and then put position on the table, and that may help. But if you're using C-arm, then it can be difficult because the C-arm will not go in and out completely. So that brings out the challenges. Now we talked about equipments like trolleys, like chairs, like post-operative beds, and simple things like tuning a machine or blood pressure cuff. And the normal standard blood pressure cuff and tuning a machine or tuning a cuff will not suffice. You may have a specialized one, you may need a specialized one in order to do that. Also, think about shifting this patient onto the OT table. If I want to shift myself, I'm 80 kilos, and if I have to shift somebody 160 kilos, you need more manpower. You need special equipments in order to shift that. So this is one paper which quotes that if the OT table is not good and the OT equipments are not good, then you may have suboptimal outcome, because the craftsman is as good as his tools are. So if you don't have the right tools, you may have the best skills, you will not have the right results. Positioning. So every trainee who undergoes me, I talk about if your position, painting and draping is good, there is very good chance that you will not struggle during your surgery. The surgery is the important bit, but the preparation is the most important bit. So positioning, while shifting the patient, mind your back. You don't want to be lifting on your own, or you're lifting with less staff. Get appropriate people, or at least appropriate equipment like pad slides. I had privilege of working in NHS, so you have got special mattresses and special equipments who can actually lift the patient onto the OT table without much stress on your back. Position. If you imagine an obese patient sitting, you will see sitting straight or sitting upright, it's quite difficult for them because they struggle to breathe. So if you have to position your patient, you have to think in what position I want to position this patient, because the position which is good for a normal patient might not be the same for an obese patient. So positions like Tendelberg or prone positions, if you are doing spine surgery, may not be a good position, or you will have to work hard to position them well so that intraoperatively you don't have any issues. Now fat patients are already padded. So we think they are fat, they have got a layer of fat which will protect them, but in fact they are more prone to iatrogenic pressure ulcers or iatrogenic nerve injuries. So they require same amount of padding, or in fact more padding than a normal thin patient, because they are taking their own weight and they have higher chance of having neuropraxia or any nerve injuries. So don't think that you don't need to pad them because they already, they have a layer of fat. You need to pad them actually more, and you need to be more mindful. So the paper that I have quoted down is work-related injuries, especially to the nurses who lift the patients, and so you have to take care of your back, be very mindful when you're shifting them. Incision. A normal size incision may not do the job for an obese patient, and I think it might be difficult to explain this to a person who is not in the surgical field, but imagine if you want to reach somewhere. Say for example, I have a marble in my pocket. I can feel it from the top, and I should be able to make a small incision and take it out. Now if that marble is in a pillow, and if I want to feel it and make an incision, and then I want to take it out, it may not be that easy. So your size of incision will definitely be bigger. So if you are an MIS surgeon and if you want to do a MIS surgery, I think that is fraught with complications. So don't think that I want to make a small incision, especially in an obese patient. If you have to make it longer, make it longer. It's not the size of the incision that will matter in the end, it is the quality of surgery that you have done. So surgery should be done very well. Don't stress that the incision is bigger than normal. If it is, it's fine. You need to make an incision as big as for you to work comfortably and give a good job. High risk of neurovascular injury. When you are operating on a fat patient, you put retractors. It can be very frustrating, especially if you're working with less equipment. And if you're not used to dealing with obese patients, then you place your retractor and you're putting the retractor. You're struggling to get the reduction, and the retractor is over the nerve, and the surgery time is usually prolonged. So iatrogenic nerve injuries are far more common than when you're operating on a normal sized patient. Some of things are counterintuitive. It's very intuitive that if you're operating on a patient with high BMI, it's going to take longer. And I'm not saying anything which is not unheard of, but I'm stressing that don't try to hurry yourself. Don't get frustrated when you are operating on an obese patient. The most important thing that you need in yourself is patience, because the surgery will not flow as smoothly as you will expect, especially when you are in the early part of your career. When you have gain experience, it doesn't really matter. For me, it doesn't really matter if I'm doing a hip replacement on a 60-year-old or 60 kg or 150 kg, because I have seen all the spectrum. But when you're starting up, be extremely patient, take a lot of time. Of course, fat is quite vascular. So if you're cutting, you will see it bleeds a lot. So, and you're taking longer. So you have that much time where blood is oozing. So yes, the blood loss and operating time is longer. And this is one article. There are many, but this is one of the articles which I have chosen which confirms the same. Fluoroscopy. If you're doing trauma surgery, fluoroscopy is your best friend. You can't see. If you don't have fluoroscopy, then it becomes so much difficult. And I really appreciate orthopedic surgeons. I'm sure Ms. Khandakar sir would have also operated when the CM was not there. And doing a good job at that time could be, was very challenging. Now, fluoroscopy is helpful, but operating on obese patient, to get a good view can be quite challenging, especially if your machine is not that good or is not that new. You may not be seeing everything as clearly as you want to. So imagine I am seeing you, and imagine if I have glasses which are fogged up and I'm trying to see you. It's the same difference. So you need a good quality C-arm. So if you have two C-arms, one is of a very high quality, keep it for an obese patient. The low quality with the C-arm which is old, which you don't see very well, keep that away and try to use the best equipment. And identification, especially in spine surgery where level is so important, it can be quite complicated. So, and this is one paper which suggests, there are many, but this is one which suggests that if you want to do a caudal epidural, it's very difficult to get a good view, even with a good quality machines, because it has to go through a lot of layer of fat. But technique and fixation choice, unfortunately, there are so many fractures which we manage in plasters very well. And Khandakar sir has given one good example of humerus, where in obese patients, if you want to treat them with plaster or with a sling or with a brace, it is quite challenging. And I remember one of my consultants when I was working in England, and he asked me, what is one definite contraindication of conservative treatment in humerus? And I gave many answers, and he said no. One of them, there are many, but he said, even a big breast is one of them because it keeps on, deforming the humerus. So there are times where a fracture which can be treated easily with plasters, we choose to do an internal fixation. As I will omit this point with retrograde nail, he has already talked about. If possible, lateral decubitus is one of the best positions for a surgeon and for the patient, because fat people, when they lie on side, they are able to breathe better, and most of the layer of fat displaces away from operative site. So position can also be important, and this is stressed in this review article which was published, I think, in JBJS. Now let's talk about some post-operative complications. The general complications in orthopedics are infection and deep vein thrombosis. So infection rate in obese patients are definitely higher. And if I have put in a figure on an arthroplasty where infection rate was less than 1% for a normal hip and knee replacement, and it is 4.6%. So some figures will say up to 5%. So it is actually 10 times a normal population. So if you are operating on an obese patient, do counsel them that the risk of infection, risk of DVT will be higher than the normal population, and that was one thing I would explain them and document them, and only if they say yes, I would be happy to operate on them. Now obese patients, there are a lot of obesity complicates. There are medical consultants here, they will know that obese patients, they have higher chance of having diabetes and so many other comorbidities. So diabetes itself is a risk factor of obesity. And if you have obese patients who is diabetic, it's like Karela upar se neem chada. So the chances of infection becomes even more. So it can be up to this tenfold also becomes too much. Risk of DVT is quite high. Intraoperatively, even if you give them stockings, वो उनको fit ही नहीं होते. So in Western worlds we use foot pumps. So calf pump लगा के we keep them pumping, and even in post-operative care we used to use them. But in India, that resource is not available to all of us. Certainly in my medical college, I don't have it. So the best thing I could do is to get them going and get them going as fast as possible on their feet. ICU and hospital stay. If you are obese, higher you go on the grade of obesity from mild, moderate, severe, the chances of you staying in ICU is definitely longer. Chances of you staying in hospital is definitely longer. And again, there are a lot of published literature, and one of them I have quoted below. Reoperation rate. And I will just stick to trauma because there is a separate session on orthoplasty. And in my own experience, even I consider myself as a reasonably experienced surgeon. And even in my hands, I feel that reoperation rates are higher in obese patients due to multiple factors, because there can be so many different challenges when you are operating on them, and these small things, when you gel them together, leads to the implant strength may not be good, your fixation could be suboptimal because you are struggling, you are short of time, you're not that patient. Multiple factors lead to higher rate of reoperation in them and higher rate of fixation failure. Mortality, I think this is one thing. Normally we don't take mortality as one of the in the consent forms. If they say that there's this percentage chance of you dying, I think in Indian patients they will all run away to somebody else. But yes, mortality itself is a risk factor, especially in obese patients, because they are comorbid. Weight itself is a risk factor, and they usually have multiple medical problems. So risk of mortality is also high in them. And this is one good review one paper, obesity trauma surgery, which reinforces many important points. If you are trying to operate or you're trying to gain any information, there is one article I would suggest that you should read. So take home message is, obese patients are very different to a normal patients when you're doing trauma surgery or any form of surgery. You have to be far more prepared yourself in terms of your skills, in terms of your patients, in terms of your equipments, getting them into the hospital, wheelchair, tourniquet, simple things can bring so many challenges. You have to be very well prepared and well planned. The risk, general risk of infection, general risk of DVT, and any other risk that you can say, you can easily say it's doubled up. अगर किसी का infection risk 1% है, अगर आप बोलोगे कि your infection risk is around, I used to quote around 2 to 3 times the normal population when I was doing orthoplasty in United Kingdom. You will be absolutely safe. Obesity associated with high reoperation rate, mortality in the normal population, and we all know that. That is why this conference, we are doing it to make it aware and try to decrease the rate of obesity, or at least, we should make your patients or your population that you deal with health conscious. Thank you so much.
Thank you very much, Dr. Vinay Kumar, for a very nice lecture. Since there is some difficulty in connecting Dr. Emmanuel Gebel online, I now invite Dr. Vivek Sharma to discuss and conclude the session. And after his discussion and conclusion, the House shall be open for questions.
It's going to be soon good evening and very less crowd, so it looks like we are discussing among ourselves. Operating on an obese patient is a big time challenge, no doubt. I still remember Pachore sir struggling to find a hip joint. We had to call in for CR for 15-20 minutes. We were just trying to find out where the hip is exactly. There was a patient of hip fracture wanted to replace. So we do the surgeries and the stress level is always high. With obese patient, the surgeon is always in stress, maybe 3 times more than the routine cases. We do the surgery, somehow we manage to get good reduction, get good implant in situ, maybe we replace it. We go back home happy that nothing is better than us. 3 days later, you are happy, the patient has gone home. 3 days later, the patient calls, कि sir dressing में से सो के जा रहा है. So next tension starts. By the time you see the patient, night is fired, you see the patient. So first question to Khandaka sir, that there is a serious discharge coming out from the hip region. We have operated for DHS and there is a serious discharge. So what do you do, sir, in such cases? Inflammatory marker, culture, routine counts, because they are always high 3 to 4 days post surgery.
Hello. The first thing, I'll call the patient to the hospital and inspect the wound. There can be various grades of infection, right from just a serious discharge, just the reddening of the wound to a frank pus. So depending on the situation, I do it. The first thing is, suppose it's just redness, I might just do some dress, observe it, start antibiotics. If it's a serious discharge of frank pus, definitely I will take him to the OT and explore the wound and do an abandonment.
Correct. So, depending upon the wound situation, if it is inflamed, red, looking, it will give us a sign that it is infected. Agreed, sir. Sir, in last 10 years, you and Ashwini sir have been practicing since more than 15 years or maybe more than that. So what do you see the trends, sir? What are the number of obese patients coming in the clinic nowadays and which it was there 10 years ago? So what is the ratio of these patients you operate nowadays?
You see, I'm into practice for last 40 years. Maybe then I am operating more patients, the proportionate number of obese patients is definitely high. And we have also become more wise when we operate obese patients. The number is definitely high. Talking of a definite number, I cannot give a number, but definitely
the number is going high. And what is the difference between the rural population and the urban population? Is there a difference? Do you see any difference?
There's a definite difference that the urban population is much more into this category.
I suppose Ashwini sir has the same opinion regarding this.
Yes, my ideas are also same. Those who are catering to the masses in the rural area, there would be less number of obese persons when while in corporate hospitals, private or in the metro setup, there would be more obese patients. This just I'm just reminded of a patient, a very obese patient. As you said, last 15 years. I'm talking about 40 years before, in my early 80s when I was a resident. There was a patient with us with fractured femur, committed upper 1/3, And the options at that time we were only doing, open gay nailing, retrograde type, not even anti-grade nailing was there. Or most of the time we were applying spicas in children, those who are not adult and adolescents. So this was adolescent. And we wanted to give him hip spica based on the age. But his thigh abdomen was so huge, this was just impossible. We tried of thinking, making a customized Thomas splint, but then again we dropped the idea because it would have been very, very difficult to take care of him on the Thomas splint. So ultimately we treated him on 90-90 traction. I mean, that was the first time I saw a fracture femur being treated with 90-90 traction, and we took care of him in the ward for 6 weeks.
Oh.
And then of course it reversed. So these kinds of things are, we have more options right now. Right now if the patient comes, we have anti-grade nailing. In children we have flexible nails and all those options. So probably now we are better equipped with dealing with obese patients.
So nowadays many patients we get in OPD, since I am in Rullabji and we have a bariatric department also there. So sometimes we refer patients to them or sometimes they refer the patient to us. This is always a confusion. They suggest for bariatric surgeries, we suggest for knee replacement. Now, according to which, even to Sandeep, what do you think? What is the trend or what is suggested that what should be done first? Bariatric surgery or knee replacement surgery? Because we always tell them that once your knees are fine, you will be able to walk well, you will be able to be more compliant to your bariatric protocols after the surgery of your bariatric surgery. Rather than having a bad knee, done your bariatric surgery with bad knee, you will not be able to lose weight later on. So what do you
definitely, sir, this is a very tricky question, and I would say that if a patient is having BMI more than 40, then these patients are very, very, I can say that doubtful patients for total knee replacement first or bariatric surgery first. But there is no conclusive evidence in the literature still which can say that which is better. So if you think that the patient is very motivated and if he gets some benefit after pain relief from the knee replacement surgery and he can reduce his or her weight after the knee replacement surgery, then we can definitely go for knee replacement.
That is the next question going to come in next slide. But what do you think which should be done first? Bariatric surgery, or we always say that bariatric surgery should be done later on. But Vinay, what is your say on that?
I would just make a comment.
Yes, sir.
You should also take into consideration the BMI levels or the waist hip ratio.
Correct.
If it is above 40 or in one of the cases that we were discussing, it was above 50. In those cases, certainly we cannot do TKR because he is bound to have very serious complications post-surgery. So BMI should also be a factor. As you said, a patient is for bariatric surgery or TKR, which you will take first. So I think BMI should also be taken into consideration. If it is less than 40, then probably
then always bariatric first. Okay.
Dr. Vinay,
I think I'm very clear in my mind. I have dealt with so many fat patients, obese patients. I should not say fat. It's a bad word. Obese patients in UK. Fortunately, in NIMS, I hardly see them, so I feel very relieved. But I am very kind. So I usually, when I am seeing a patient, obese patient for a knee replacement, bariatric surgery is not something which comes into my mind that I should send the patient first. So I will do it first, always. Whether the patient has the bariatric surgery done or not, it doesn't really bother me. If you talk about evidence, there are evidence where they have studies where they divided patient in 3 groups. One patient had surgery without bariatric surgery, one patient had bariatric surgery and then surgery within 2 hours, 2 years of having bariatric surgery, and the third group having surgery after 2 years of getting the bariatric surgery done. I think the only difference was that the surgery was slightly faster. Apart from them, there was no difference in complication in either of the group. So for me, always knee replacement first. I don't really care about bariatric surgery. Yes, but when I'm operating on them, I'm crystal clear. I tell them that your rate of complication will be 3 to 5 times higher than a normal population. If you sign this deal, I will operate on you.
Sir, your comments.
This is also said that if you do the knees first, they are unlikely to reduce weight.
Yeah.
Correct.
It's a myth.
Yes.
People saying.
No, that is in the next question, sir. I'll come up. So according to literature, yes, there are 3 to 4 times more complication rates in patients with obese BMI index more than 35. This thing, but very rarely, as Vinay said, that you suggest the patient for the complications. You tell them the complication rate is going to be high. Few literatures, they also say that the BMI has got no role in the complication, but that is controversial. Majority of them say that do the bariatric surgery first, then do the knee replacement. Do you think we have advised a obese patient for knee replacement surgery? We tell them that once your knees are done, you will be active, you will be walking, you will be more, you will be doing more exercises in your daily routine. So do they really lose weight in your practice? What do you think?
I don't think so they lose weight, but definitely their lifestyle gets better after the pain relief from the knee replacement surgery, and definitely there are high risk of complication, but if we communicate well with the patient and their attendants, then we can go for total knee replacement or total hip replacement. We can't deny these patients for the benefit from the benefit of joint replacement surgery.
Vinay? As you said, it's a myth.
I think it's a myth. The patients are obese because they love their food, and it's very hard to explain them not to like their food. So, in my experience, the biggest thing or the most difficult thing these people find is to lose weight. And after the surgery, I don't think there is evidence to suggest that they will lose more weight, because it's all about diet. You cannot do impact exercises after knee replacement. The maximum you can do is walk. You walk for half an hour, and if you eat a piece of chocolate, and it's gone. So I do my knee replacement for patients who are obese, so that they can walk up to the fridge without any pain, and they can grab what they want to grab, and they can come back and enjoy it. That is my motto of life, and that is why I was very popular in Glasgow, because most surgeons will refuse all fat patients. They came to me. I had few superficial infections, which I struggled, but I had back dressing. Fortunately, finger crossed, I've never been burned by a deep infection in fat patients. They are the most thankful patients after rheumatoid.
Yes, they are
I can
most
guarantee you
thankful
that.
patients.
They are the most thankful patients
Yes, agree.
after rheumatoid. Rheumatoid patients are the most thankful patients. They will say thank you very much, and the second will be the obese patients walking with a box of chocolate for you.
Sir, what is your say on that?
I think what Vinay said is very true, that the basic aim of offering a hip or knee replacement is pain relief, and that's the patient is very happy whether obese or not obese.
Because they have lost their zeal, sir, because every day when the knees are aching, the hip is aching, they feel that okay, once become painless, we'll do this, we'll do that, but they really don't. They really don't.
The same food tastes much nicer after knee replacement because the pain is gone.
Second thing, if in case there is a patient and is not willing for knee replacement, they say that okay, we'll try to reduce weight. What regime do you suggest? What regime? Because they are not going to walk, they are not going to run at all. So what regime, what exercise regime do you suggest them for reducing weight?
I think I'm not the best person to answer. I'll send it to a nutritionist, somebody who deals with nutrition, because it's very difficult. So as an orthopedic surgeon, I think I'm not the best person. I will send it to a dietitian, and I hope I will wish them best of luck. If they can succeed, that will be great, but it will not be me who will be giving any form of exercise regime to them.
Sir, any suggestion for that?
If I ask them to cut down on their food, they do not come back to me.
Yes, they never come back. Once they reduce their weight.
Well, one exercise which I teach all my patients who said, डॉक्टर साहब वजन कैसे कम होगा? मैंने कहा एक ही एक्सरसाइज बताऊंगा जिससे वजन बहुत तेजी से कम हो सकता है. वो ये कि जब भी कोई खाने को देना तो सर पैर इधर करना है, फिर इधर करना है, फिर इधर करना है, इधर करना है. जब भी कोई खाना दे बस सर को इधर से इधर करो. If you can do this exercise and you can fulfill this exercise, you will definitely lose weight.
There was this lady, she was 42. Last year she had come to me, and cycling and swimming, which I suggest to them, that you'll have to learn these two to reduce weight, because you cannot walk.
Weight elimination exercises.
Weight elimination exercises, yes.
साइकिल चलाएंगे, वो फिर टूटेंगे और खंडा का सर के पास आएंगे.
No, the athlete wala cycle, the home stationary cycle.
Swimming.
Swimming, yes, it's a very good exercise.
Yoga, cycling, and swimming is the best.
it's been already included in the previous slide that obesity, there is a cushioning effect on the hip joint, so I'm not taking it there. There is a obesity paradox. It means that as compared to their counterpart on the other side of the scale, the BMI scale. So in obesity paradox, according to it, that these obese patients have got less complications as compared to those patients in their BMI of 20s or 22 or 23. So this is the last slide I would suggest, and everything has been included. Anything you want to say?
Well, I am a medicine man and we come across cases of neuropathy. And neuropathy with diabetes, slightly obese. So, with this, if this neuropathy comes into play, would you like to do any change in your priority of bilateral knee replacement? In cases of neuropathy and slight obesity, will you still go for bilateral knee replacement?
So the only neuropathy, if it is affecting the gait cycle, if it is affecting the quadriceps power, because our main criteria or main criteria to operate on them is to have a good quadriceps muscle power, first thing. If they have it, then I think there is no contraindication to that.
I think we are quite fortunate that when we deal with diabetics with neuropathy, usually it's quite distal. And we see, distal dry gangrene or, ulcers which have been there for a long time and which take longer to heal. So if the neuropathy is so bad that they are having, the skin condition is not good, if you have ulcer, then it itself is a contraindication for surgery. With diabetics with peripheral neuropathy, I think I would never do a bilateral. Even unilateral becomes a challenge. And if the neuropathy is so proximal, by the time it is proximal, they end up having amputation anyway. So TKR is out of question.
To our second day of the conference, and we will initiate our first session on topic the association of obesity and cardiac remodeling in adults, an insight into epicardial adipose tissue in obesity related cardiac dysfunction. And to talk on this topic, I would like to invite our eminent speaker, Dr. Dalia Biswas. And to chair the session, I would like to invite Dr. Aparna Garg ma'am, Professor and Head, Department of Physiology, Mahatma Gandhi Medical College and Hospital, Jaipur. Dr. Dipesh Agrawal sir, Professor, Department of Cardiology, Mahatma Gandhi Medical College and Hospital. Dr. Pradeep Agrawal, Professor, Department of General Medicine, Mahatma Gandhi Medical College and Hospital. And Dr. C.M. Agrawal, Emeritus Professor, Department of General Medicine, Mahatma Gandhi Medical College and Hospital. Now I would like to request Dr. Aparna ma'am to introduce the speaker, please.
A very good morning to all the delegates present here. It's my privilege to... Should I change or wait? It's my great privilege to welcome and read the CV for Dr. Dalia Biswas. Just an add-on information rather than the CV, she has been my PG guide when I was doing my post-graduation in 2008. So, the CV says it all. She is the convener for the exams in the Communitee Institute of Medical Sciences, Wardha. She is ex-Wisely Newty academics from Jawaharlal Nehru Medical College, Wardha. Publication index total account to 75 national and international. Books and chapters have been 9. She was a pioneer in organizing the IMSACON in 2010, where we played a vital role. We were her students and we did the task allotted to us very nicely. Without saying, she is the best teacher and selected at rank first for International Journal, IMSA Journal of International Medical Sciences at Academy, best published article 2010. I welcome you, ma'am, to continue with your session.
Good morning, all of you. Today we start with the first topic on the association of obesity and cardiac dysfunction. So without wasting any time, I will start with my talk. The title is Association of Obesity and Cardiac Remodeling in Adults. Obesity and cardiac remodeling in adults, the index will be on this line of talk today. epicardial adipose tissue in obesity-related cardiac dysfunction, namely atrial fibrillation. So we'll just deal about, it's a big topic, obesity and heart functions. We'll mainly talk about the cardiac remodeling in adults, in adult population, and the atrial fibrillation, mainly which is caused because of epicardial tissue dysfunction. To start with, the World Health Organization, WHO, defines overweight and obesity as a pathological setting with abnormal or excessive fat accumulation. Accumulating evidence supports the notion that sedentary behavior is a strong predictor of obesity and detrimental changes in metabolic traits. Etiology of obesity: environmental, genetic, behavioral aspects, and sedentary behavior. Etiology. Now, lifestyle factors which contribute to obesity: prolonged positive energy balance, sedentary behavior, circadian alignment, sleep quality, and diet. Now, this is the prevalence of obesity all over the globe. As you can see, India also contributes substantially. Coming to the cardiac changes in obesity. Thickening of the myocardium. We come to the problem of metabolic syndrome. Contributors are abdominal obesity, elevated blood pressure, impaired fasting glucose, and dyslipidemia. See the position of the heart. These are the yellow ones, epicardial fat, which will be our topic of discussion today. This is the visceral pericardium, and this is the parietal pericardium. This is the myocardium, and this is the pericardial fat, which will be our topic of discussion, which contributes a lot of problem for the development of AF or atrial fibrillation. Cardiac changes in obesity. In obesity, if you see, there is alteration in nutrition, gut microbiota, and neurohumoral activity. Serious changes, if you see, this compromise cardiac energy metabolism, contractile and relaxation function, and cardiac survival. There is heart failure with preserved or reduced ejection fraction, and changes in the nutrition status, gut microbiota, and physical exercise are also indispensable for the development of CVD in obesity. Now, there is a new term called as obesity cardiomyopathy. This obesity cardiomyopathy develops independent of hypertension, coronary artery disease, and other heart diseases. Epidemiological, clinical, and experimental evidence. The clinical findings have consolidated the presence of left ventricular dysfunction in obesity. This is already known, left ventricular dysfunction in obesity. Experimental investigations have uncovered pathophysiological changes in myocardial structure and function in genetically predisposed and diet-induced obesity. This is a picture of obesity cardiomyopathy. You can see the enlargement of the heart, how much it is enlarged compared to the normal. Now, the etiology of obesity cardiomyopathy. These are all the causes of obesity cardiomyopathy: adipose tissue dysfunction, systemic inflammation, metabolic disturbances. On the other side, altered intracellular, especially mitochondrial, calcium homeostasis, oxidative stress, autophagy, or mitophagy defect. Third is the myocardial fibrosis, dampened coronary flow reserve. And lastly, the coronary microvascular disease, especially the microangiopathy and endothelial impairment. Now the remodeling in obesity in context to heart. The cardiac remodeling in obesity. Long-term obesity is closely associated with cardiac remodeling, which is characterized as left ventricular hypertrophy, cardiac fibrosis, and diastolic dysfunction that eventually evolves to overt heart failure. Fat accumulation in the form of deposition of metabolically active visceral adipose tissue, which is called as VAT, and pericardial fat causes a higher cardiac output and workload, leading to an enlargement of the left ventricle to meet increased energy requirement. Adipose tissue we have already seen. Again revising, this is the paracardial fat, this one, and this is the perivascular fat. This is the epicardial fat, and here is the pericardial fat. Obesity impacts myocardial electrophysiology, resulting in an increased prevalence of AF, that is atrial fibrillation. Regardless of structural or electrophysiological remodeling abnormalities, obesity serves as an independent culprit factor for the occurrence of cardiac hypertrophy and contractile dysfunction. Now the role of the epicardial tissue. Epicardial adipose tissue in cardiac related dysfunctions. What is the role of the epicardial tissue, which is our main topic of discussion? The current evidence proposes that excess adiposity causes systemic inflammation and oxidative stress. These are the big markers of heart problem in obesity, which leads to adverse atrial remodeling. This adverse atrial remodeling includes atrial fibrosis, atrial dilatation, decreased electrical conduction between atrial myocytes, and altered ionic currents, making atrial tissue more vulnerable to both the initiation and maintenance of AF. Now come to the role of adipose tissue. What? White adipose tissue is the most abundant type of adipose tissue in the human body. The main function of what is storing energy in the form of triglycerides and secreting hormones that regulate hunger, satiety metabolism, and inflammatory response. White adipocytes are bigger than brown adipocytes. They contain large fat droplets and few mitochondria. Now this what can be subdivided into subcutaneous and visceral adipose tissue, which are labeled as SAT and VAT. While SAT occupies the space just beneath the layer of the skin, VAT resides deeper and wraps around internal organs, including the heart and blood vessels. Epicardial fat. A special type of VAT, that is the visceral adipose tissue, includes epicardial fat, which directly lies over the surface of the myocardium with no intervening facial plane and shares the same microcirculation as the epicardium. This is the peculiarity of epicardial fat. It shares the same microcirculation as the epicardium. Additionally, epicardial adipose tissue also contains ganglionated plexi and intrinsic cardiac nervous system that directly innervates the myocardium. Its unique position allows epicardial fat to exert direct influence on underlying atrial tissue. This is what you can see, the comparison of the EAT and the SAT. These are levels of expression of messenger RNA and the adiponectin and the leptin types of adipocytes. This is the subcutaneous fat, this is the visceral fat, and this is the organ. These are the organs. This is the subcutaneous fat, and this is the visceral fat, which we are concerned about. What? White adipose tissue, which is again subdivided into vat, visceral adipose tissue. This vat contains more immune cells, including macrophages, which are key regulators of a chronic, low-grade systemic inflammatory state in obesity. VAT. Low-grade systemic inflammatory state in obesity. Contributor. What's a remodeling during obesity of adipose tissue? In a state of positive energy balance, such as obesity, adipose tissue undergoes several remodeling processes to increase its lipid storage capacity. Adipocytes in VAT undergo hypertrophy, which is increase in cell size of existing mature adipocytes, and hyperplasia, that is increase in cell number of resident adipocyte precursors. Adipocyte hypertrophy that exceeds angiogenesis capacity creates areas of local hypoxia, leading to cell necrosis and subsequently recruitment of macrophages and other immune cells. These immune cells adopt pro-inflammatory phenotypes in an obese state, creating a chronic, low-grade, systemic inflammatory state leading to a spectrum of metabolic abnormalities. Extracellular matrix surrounding these cells also has excess deposition of collagen, elastin and fibronectin, which leads to increased fibrosis and thus rigidity of the extracellular matrix, which physically limits the expansion of adipocyte mass. As obesity progresses, the maximal lipid storage capacity is exceeded and lipid storage shifts to ectopic sites like viscera, heart and vasculature. Now, obesity and AF. The special cardiac dysfunction in obesity is atrial fibrillation. These are the causative relationship between obesity and AF. Epidemiologically, if you see, there is an increased risk in prospective cohorts. The risk factors, if you take into consideration, it is hypertension, diabetes and heart failure contributing to AF. Mechanistic evidence, if you take into consideration, it is cardiac remodeling, electrophysiology changes and pericardial fat. If you take clinical evidence into consideration, it is weight reduction reduces AF risk. Now this is the picture, this is a normal cardiogram and you can see the changes of atrial fibrillations. Talking about AF, atrial fibrillation, there are multiple theories regarding the mechanisms of AF dating back to the early 1900s. Classical models of AF include rapidly firing atrial ectopic foci, single re-entry circuits and multiple functional re-entrant circuits. This is the AF causing this is the atrial remodeling, structural plus electrical, the ectopic activity and autonomic imbalance caused by obesity. Obesity causes, these are all contributors, hypertension, diabetes mellitus, heart failure, ischemic heart disease and obstructive sleep apnea. Now these cause impaired hemodynamic, ventricular adaptation, myocardial ischemia, inflammation and neurohormonal activation. This leads to autonomic imbalance, this leads to atrial remodeling, especially structural and electrical, and this inflammatory leads to ectopic activity. All these contributes to AF are atrial fibrillation. Epidemiology of obesity and AF. The prevalence of AF worldwide is around 33.5 million patients, and it affects 2.5 to 3.5% of all individuals across the globe. Although there is slightly more limited data on the Asian population, a nationwide cohort in Taiwan showed a 16% and 14% lifetime risk of AF in men and women respectively. The incidence of AF is also predicted to double from 1.2 million cases in 2010 to 2.6 million cases in 2013, while the prevalence is projected to increase from 5.2 million in 2010 to 12.1 million cases in 2030. Importantly, as 1/3 of the total AF population is asymptomatic, these numbers are likely to be underestimated. Why there is increased prevalence of AF? Age is one of the strongest risk factors for AF. The aging of overall population significantly contributes to the increased prevalence of AF. Among modifiable risk factors like hypertension, diabetes mellitus, obstructive sleep apnea, myocardial infarction and heart failure, obesity is strongly associated with AF. There are multiple lines of evidence linking obesity and AF. Numerous epidemiological studies have shown that obesity with new onset AF, even after adjustment for other comorbidities associated with obesity, a meta-analysis of 51 studies with over 6 lakh individuals by Wong et al. Showed a 29% greater risk of overall incident AF and a 10% greater risk of post-operative AF for each 5-unit increase in BMI. The key question is what drives the increase in the AF burden? Changes in intrinsic characteristic of the population remain the major driver of increased AF prevalence and incidence. Atrial fibrillation, as you can see, the normal heartbeat and the irregular heartbeat of atrial fibrillation. The normal heartbeat and irregular heartbeat. Atrial fibrillation. Now, ECG tracing, normal sinus rhythm. This is the atrial flutter and this is the atrial fibrillation. Over the past several decades, the multiple re-entrant circuit theory has been the dominant conceptual model of AF. The re-entry circuit model of AF, there must be triggers to initiate and there should be vulnerable substrates to sustain the circuits. See, this is the picture of the re-entry circuits which causes initiation and propagation of the AF. This is the fast conduction pathway and this is the slow conduction pathway. Now, this is the fast conduction pathway, impulse is traveling. It tries to go, it sees a block and it stops. What happens next? This is the impulse which travels, it goes, it crosses the block and again follows. This is called as the circle theory of AF. Re-entrance arrhythmias. The most frequent mechanism of arrhythmia in humans are supraventricular or ventricular. Essential element of re-entrant arrhythmia. What has to be present in re-entrant arrhythmia? Presence of a closed loop of electrically excitable tissue, heterogeneity of electrophysiological properties, that is the conduction velocity and the refractoriness, and an initiator to begin the re-entry process. These three are the requirements for a re-entry mechanism of AF. AF triggers are mainly located in the pulmonary veins. The ones which start AF, these triggers are situated in the pulmonary veins and originate from sleeves of the atrial muscle that extend from the left atrium several centimeters into the pulmonary veins. Now, the cause of the AF is either triggered activity or automatic activity. So, we are going to see now mainly is caused by the triggered activities. The trigger we have seen, it's in the pulmonary veins. So, ectopic activities that initiate re-entry circuits can be caused by triggered activity. These are called as EH and DADs. EH means early after depolarization and delayed after depolarization. This is a picture of EH and this is the picture of DAD. Early after depolarization looks this way. This is the delayed after depolarization, looks this. This one, early after depolarization occurs phase 2, phase 3. This is the EH, and this one occurs in the phase 4 of the action potential. Triggered activity. Early after depolarizations are spontaneous depolarization of the cell membrane during phase 2 and phase 3 of action potentials and are caused by abnormal openings of calcium channel or sodium channels. DADs, delayed after depolarizations, are spontaneous depolarization during phase 4 of action potential and are caused by spontaneous releases of calcium from internal calcium store into cytosol, which leads to activation of sodium calcium exchanger. Ectopic activities that initiate re-entry circuits can be caused by automaticity also. One is triggered activity, other is automaticity. Automaticity is caused by diastolic depolarization. Diastolic depolarization from a net inward current during phase 4 of action potentials, most commonly from the funny current or the HCN channels. Unlike cells of sinoatrial node, which spontaneously initiate action potentials by diastolic depolarization, mature atrial and ventricular myocytes do not express HCN channels and thus lack this capability. In normal atrial tissue, the most common mechanism of ectopic activities that initiate AF is DADs, that is delayed atrial after depolarization. If you see the process of AF, electrical remodeling, which occurs in the sodium and the calcium channels, the structural remodeling, which includes the atrial dilatation and fibrosis. These lead to atrial fibrillation, and atrial fibrillation once again leads to this reversibility of the process. Shortened APD, ERP, this is effective refractory period, which is mainly taken into calculation for finding out AF. Conduction abnormality, which causes re-entry substrate, which causes AF. Now, autonomic neural control, calcium handling abnormality, they lead to EH and DADs, which lead to ectopic activity as trigger, and this leads to atrial fibrillation. So, this is the process of AF. Now, if you see, this is the JICR report. This is the epicardial adipose tissue and AF. You can see from this graph, there is an increasing level of interleukin 1 beta in epicardial adipose tissue, which is associated with persistent atrial fibrillation. This is the control, this is the AF. Role of adiponectin and interleukin 1 beta. AF risk factors. Modifiable atrial fibrillation risk factors, modifiable, can be modified. Obesity, obstructive sleep apnea, hypertension, diabetes mellitus, and alcohol consumption. Mechanisms underlying obesity-related AF. The pathophysiology of obesity-related AF is multifactorial. Changes that increase the propensity of AF initiation, which is the triggers, and or create a more vulnerable substrate for AF maintenance. Now, causes are hemodynamic changes, adipokines, roles of epicardial fat in obesity-related AF, and oxidative stress. So these are the contributors of AF in obesity. We will talk only on this. Adipokines, our topic of lecture today. Adipokines are paracrines. They are secreted by adipocytes. These adipokines also modulate the degree of systemic inflammation and could affect atrial remodeling and thus the risk of AF. Adiponectin is the most abundant adipokine in the body. It has anti-inflammatory and anti-fibrotic effects and is considered cardioprotective. Cardioprotective, adiponectin, which is a adipokine. It is cardioprotective to vascular endothelial and cardiomyocytes. Talking about adiponectin, which is a type of adipocyte, a series of 100 patients undergoing cardiac surgeries demonstrated that increased epicardial fat volume measured by CT was associated with decreased expression of adiponectin in epicardial adipose tissue, hinting at the role of adiponectin in atrial remodeling and perhaps AF. However, there are mixed findings in terms of relationship between serum adiponectin and AF. For example, a case control study of 84 individuals with AF and 84 individuals in sinus rhythm showed that individuals with AF had significantly higher levels of serum adiponectin than those in sinus rhythm. Now, obesity-related AF, oxidative stress and role of epicardial fat, most contributors. Oxidative stress, cardiomyocytes have an increased uptake of free fatty acids, leading to increased fatty acid beta oxidation. This overall increase in oxidative stress leads to both structural and electrical remodeling of atrial tissue. Now, the epicardial fat, epicardial adipose tissue exerts direct mechanical and chemical influences on underlying atrial tissue, because we have seen that there is a very thin structural plane between the epicardial fat and the atrium. Alteration in both electrical and structural properties of atrial tissue causes initiation, maintenance of AF and re-entry circuits. Now, what to do? This is the reverse remodel. This is obesity, this is the normal person, obesity and AF, low AF recurrence. What to do? There is inflammation, fibrosis, and there is reverse remodel. Just do weight loss. There will be increase in atrial refractory period, effective refractory period, and increase in conduction velocity, which will decrease inflammation, fibrosis, and reverse the remodeling of atrium. Some studies, reversibility of obesity-induced AF and remodeling, multiple studies have shown. Lifestyle modification programs showed that long-term sustained weight loss was associated with maintenance of sinus rhythm, reduction of AF-associated symptoms, and delay in progression of AF from paroxysmal to persistent, shifting from paroxysmal to persistent. Another study of atrial fibrillation with obesity, that also showed the same. The study was on this bariatric surgery with resultant weight loss prior to AF catheter ablation had a lower rate of AF recurrence than those who did not undergo bariatric surgery. A meta-analysis of patients with weight loss either by lifestyle modification or bariatric surgery showed a dose response reduction in the frequency of AF recurrence after AF ablation. Mechanistically, this may be explained by atrial reverse remodeling and low AF recurrence. There are only two ways of controlling this AF. One One is lifestyle modification and another is AF ablation and drugs. So to summarize today, we have seen today obesity cardiomyopathy and the atrial fibrillation. Take home message: as obesity plays a critical role in incident and recurrent AF, the reversibility of this process has significant public health implications as the rate of obesity continues to grow worldwide. References? Thank you.
Very much, madam. And it was wonderful insight regarding the atrial fibrillation basically, and the reason was obesity definitely. So regarding your talk, this was included all the pathophysiological processes and mechanism of development of atrial fibrillation in patient of obesity. So why we are worried about atrial fibrillation in obesity? Probably atrial fibrillation itself is a very great complication and it can lead to stroke. And the talk of atrial fibrillation is because this is probably in obesity patient is less talked about and less diagnosed. So as she pointed out, the prevalence increases. Probably this is underreported entity because many a times people do not know they are having atrial fibrillation, and if they are asymptomatic, this can be diagnosed by the Holter monitoring. And if you go with the Holter monitoring in general population, we can see that the incidence and prevalence of atrial fibrillation is probably double or triple as we have data with us for the revealed atrial fibrillation. So probably if we go with the general public for atrial fibrillation diagnosis, if any patient is having slight symptoms of irregular rhythm, they can be monitored and they can be diagnosed with the atrial fibrillation. And with obesity and cardiac diseases, we have many of the cardiac diseases that are pointed because of obesity, like heart failure, hypertension, diabetes, dyslipidemia, and other cardiac rhythm as well. So wonderful lecture, ma'am. Thank you very much. Thank you for the, and probably question answer will take after the end of the session. Thank you.
Now we are moving to another talk, and I would like to invite our very eminent cardiologist, Dr. Rajeev Gupta sir, and I request the chairpersons to please introduce our speaker.
Affiliated with Internal Hospital and Cardiac Care Center. He is a visiting professor in this university and is a ICMR member for steering committee. He is one of member of the board and director of WHS in Geneva and distinguished scientist in British Institute of Scientific Research, Jaipur. He has number of articles in national and international journals. He have number of articles work on the cardiac preventive medicine especially, and he is editor of IMSACON Journal of Health Sciences. He has given many lectures in national and international conferences like SEC and EST. So I'd like to invite Dr. Rajeev Gupta for her insight on cardiac manifestation in obesity.
Thank you very much for your kind introduction. We heard a brilliant talk on the complications of obesity in terms of cardiac remodeling, hypertrophy, and atrial fibrillation, which are, of course, very important topics in obesity. What I'm going to talk today is about the cardiovascular disease. What is the pathophysiology and how can we manage? And is obesity a cardiovascular risk factor? Just the data from the global burden of disease and clearly showing that BMI is one of the more important increasing risk factor across the globe. Almost 1.83 kilograms per meter square increase per decade, which is a very high increase in the BMI. And that translates into the global obesity prevalence. The highest prevalence, of course, in US, in Central Asia, in South Africa, and some parts of South America. India right now is not a very low, high incidence, high prevalence area, but it's going to shortly to be. Now we have been working on epidemiology of risk factors in Jaipur for many years now. First cut, many published some 15 years ago, clearly showing that across the time span, the prevalence of obesity and truncal obesity both were increasing, both have increased in Jaipur, and currently almost half of our population has overweight, BMI of more than 25 or more. Now these data translates into India-wide data also. In India, generalized obesity is highly prevalent. Northern states, southern states, they all have high BMI of more than 25. And if you look at the urban population, almost everywhere in the country is all red. That means more than 25% of the population has, in the urban areas of the country, have the problem of overweight, obesity. And the same thing is true for abdominal obesity, which is a different kind of obesity, possibly more toxic. We have just about the clinical problems due to obesity. It can cause number of medical complications across the system. You have increased pulmonary disease, non-alcoholic fatty liver disease, gallbladder, gynecological problems, we heard yesterday, intracranial hypertension, stroke, cataracts. Today what our focus is basically coronary heart disease or cardiovascular disease, diabetes, dyslipidemia, hypertension, and of course cancer. Global burden of disease has shown the contribution of obesity or high BMI in various disease burden. So this is disease burden, or DELIS as they call it. The most important disease burden is cardiovascular disease. Number 2 is diabetes, and number 3 is cancer. So remember that. These are 3 important contributions from obesity. And I see Dr. Shoaib here. Mental disorders is also very common in obesity. I think it doesn't cause so much of deaths, but it causes a lot of disabilities. And deaths, of course, cardiovascular disease is the one cause of death in people who are obese. Now, what's the progression? What happens to the cardiovascular system when it evolves, when the obesity evolves? And I think that's very important for all the undergraduates to understand that a person, if he follows a very healthy lifestyle, has no risk factors. He is not obese. The BMI is less than 25, no abdominal obesity, blood pressure well controlled, less than 120 systolic, no diabetes, no smoking. But as soon as you get into stage 1, which is the excess or dysfunctional adipose tissue, we just heard in the last talk about the dysfunctional adipose tissue in the terms of rat. And then you have overweight, obesity, abdominal obesity. There is also association with impaired glucose tolerance. And in the second stage, what comes in is the metabolic risk factors. So obesity leads to hypertension. It leads to hypertriglyceridemia. It leads to type 2 diabetes. There is a high risk of chronic kidney disease, and there is a risk of metabolic syndrome. So all these risk factors, they combine together to develop firstly subclinical atherosclerosis, then there are subclinical heart failure, and ultimately leading to coronary artery disease or stroke or peripheral artery disease. I won't talk about atrial fibrillation and heart failure, which was talked in the last lecture. Same thing happening in Jaipur also. In the Jaipur Heart Watch across the years, we have seen increasing obesity, and it correlates very strongly with increasing hypertension, increasing high cholesterol, increasing high triglycerides, and increasing diabetes. So everything which is at the micro level is happening in an individual patient, is also happening in the population. Now this is the biology of risk factors, that what happens, what are the atherosclerosis risk factors in obesity. Now there are, so number 1 change is decrease in the HDL cholesterol. Adiponectin we just about, decrease in the adiponectin, increase in TNF alpha, and visceral adipose tissue, all lead to insulin resistance. Insulin resistance in terms of lead to reactive oxidation species, interleukin 6, increase in the inflammatory markers like CRP, endothelial dysfunction. And all these endothelial dysfunction is the beginning of atherosclerosis. Remember that. Unless the endothelium is, as long as the endothelium is healthy, there is no evidence of dysfunction. There is no process initiation of atherosclerotic cardiovascular disease. The first thing which happens in atherosclerosis is endothelial dysfunction, and that is, I think, contribution of obesity because of the intermediate vascular factors, the biomarkers, which causes all this problem. We already heard about the heart failure thing, that heart failure is a very important consequence of obesity. There are myocardial fat deposition, insulin resistance, liver steatosis, altered metabolic profile, increasing heart rate, conduction defects, all lead to heart failure. And then of course there are multiple mechanisms. I won't talk about that because it has already been said. Cardiac arrhythmias, we just about the atrial fibrillation, but other arrhythmias are also equally important. The ventricular arrhythmias are also important. We heard about atrial remodeling, fibrosis, endothelial receptor factors, abnormal atrial conduction, which causes atrial fibrillation. But there is a QRS fragmentation. That means the QRS duration is increased. There is fibrosis in the myocardium, ion channel remodeling, connection proteins, adipose tissue. They all lead to ventricular tachycardia. So it's not only the atrial arrhythmias which are important, it is also the ventricular arrhythmias which is also an important consequence of atrial of obesity. In the last few months, we have been hearing about sudden deaths happening in gymnasiums, actors dying prematurely, people dying at young age. And one of the factors is obesity. They are there in the gym to reduce obesity. They do unaccustomed exercise, and because of the pre-existing substrate, pre-existing ventricular abnormalities, they develop sudden cardiac death. It is not COVID, it is ventricular, it is obesity which is killing them. And that's the, I think, information we need to clarify, because I think Mahatma Gandhi was a part of the COVID case control study just published in the Indian Journal of Medical Research, showing clearly that COVID or vaccination had no association with sudden cardiac death in young people. It was a case control, a large case control study. I'll also focus on a bit on the clinical interventions, because I think ultimately as clinicians, as physicians, we need to know that whether clinical intervention, what are the clinical interventions which are required and whether they help or not. So how can we reduce the cardiovascular risk in obesity? How can we reverse the excess or dysfunctional adiposity? And remember that it's only the first stage of excessive obesity which is reversible, which is dysfunctional fat, which we can reverse by treating obesity. Once it goes beyond the first stage, nothing is reversible. It's all, you can just reduce the progression of the risk. You cannot totally reduce the cardiovascular risk. The only way to reduce is healthy lifestyle. I'll just talk about that. Pharmacotherapies are important, and bariatric surgery, of course. I won't talk about that because it has already been discussed. Eating is important, and we don't know what to eat, so it's very difficult to figure out what to eat, and there have been number of thousands and lakhs of millions of trials of fat, diet, atherosclerosis, everything, as you can see. What I believe is that it is not the overall, it's not the individual component of diet which is important. It is the overall diet constituents. There are a number of healthy diets if you are in Europe. Mediterranean diet, both Spanish or French. Indo-Mediterranean diet is basically derived from the Central Asia, in Israel and Palestine. You have certain healthy forms of diet, which is Turkey, of course, is a very, very useful Indo-Mediterranean diet. Jazz diet in the US, healthy living index in the UK. Then there are the Lancet Commission diet on sustainable future, and you have diverse plant-based foods, low amount of animal sources, which is high unsaturated fats, no trans fats, and there's less refined grains and processed foods and sugars. And finally, we have the Pure Study, and Pure Study was also conducted in India. We are part of it, which focuses on fruits, high intake of fruits, vegetables, nuts, legumes, dairy products, including yogurt and curds and milk, and fish, with a low intake of refined carbohydrates. So I think this is very important for you to remember that diet is not the individual food component, it's the overall constitution of the diet which is very important. You need to have 1200 to 1400 calorie per day diet if you want to reduce weight. Intermittent fasting is a good way to do that, at least 12 to 14 hours of fast every day, like the ancient Indian diet. Exercise is again a controversial topic. In obese people, start slow, but 150 minutes per week. We need to mix intensity aerobic exercises. We need to do some resistance exercises, sub-balancing exercises. And as far as the evolutionary perspective is concerned, we need to exercise several hours a week, mostly cardio, but also some weights, and keep it up as you age. US guideline 150 minutes are minimum. So what are the how to improve physical fitness for prevention in obesity? We need to do aerobics like walking, jogging, cycling or swimming. We need to have commute-related physical activity. You can walk to your work, you can walk from parking space to your work, park your car at a slightly longer distance. Weight training are important. Gym-based training, I already told you about the harms of gym-based training, which is you have to go very, very slow. And then you have to have balancing exercises, and yoga, of course, is also a very strong way to not reduce weight, but to improve your fitness. And there are lots of benefits beyond obesity which happens in obese people. You reduce adiposity. You also reduce blood pressure if you exercise. You reduce inflammatory markers like CRP, like interleukins, they all go down. Insulin resistance goes down, heart rate goes down, the sympathetic activity also goes down. And then there are decrease in stress, decrease in depression and anxiety, and improvement in cognitive function. So there are lots of benefits of exercise alone in obese people. And now in the era of pharmacotherapy, we are in the era of pharmacotherapy of obesity. I just show you how can anti-obesity drugs reduce cardiovascular risk, which was not there before. Actually, all these years, for the last 50 years or so, obesity is not a part of a major cardiovascular risk factors. Because if you reduce obesity, the risk doesn't go away. And there have been lots of trials, which have randomized controlled trials, which have shown that obesity reduction, only obesity reduction leads to decrease in the cardiovascular events. So it is not a major risk factor so far. But what I'm going to show you today is that obesity now is a strong challenge, strong concept that it is a major cardiovascular risk factor, because lots of drugs have shown benefit in reducing cardiovascular risk if you treat obesity with these type of drugs. So GLP-1 receptor antagonist or receptor agonist basically used for diabetes management, but now also for obesity management. And you have a number of drugs, liraglutide, semaglutide, tirzepatide, and so they are single GLP-1 receptor agonists. They are dual receptor agonists, and this is a triple receptor agonist. They all reduce weight, and depending on the molecule, by liraglutide over a period of 2 years, 8.4, semaglutide injectable 14%, oral also 14%, and the dual agonist tirzepatide is 19% over a period of 2 years. Orforglipron is still emerging. It is only a 6-month trial, but I expect that it will also reduce the weight about 20%. So these are the various weight loss interventions. GLP-1, then there are certain older drugs like diethylpropion, naltrexone, and orlistat, which orlistat is at least available in our country, reduce weight by about 10%, and then of course the surgical interventions. So how do you tackle obesity to reduce cardiovascular risk? The initial drugs, 5% loss, and the recent drugs like tirzepatide and the gastric bypass surgeries showing a tremendous benefit in terms of reducing obesity, reducing cardiovascular risk. So reducing obesity per se reduces cardiovascular risk. That is well known now, because all the trials have shown that. But whether it reduces cardiovascular event, the only one trial, the SELECT trial, just published early November, which is in middle of November last month actually. Semaglutide in cardiovascular outcomes in obesity without diabetes. So it enrolls obese people. You may have more than 30, no diabetes, having pre-existing heart disease. Half of them had heart disease, half of them were normal, and then followed up for about 4 years. and the slide is missing. But what it shows was in pre-existing cardiovascular disease and overweight or obesity, but without diabetes, weekly injections of semaglutide 2.4 reduced the incidence of death from cardiovascular causes, myocardial infarction or stroke at 40-month follow-up. So almost 4-year follow-up, so there was a reduction in cardiovascular disease, and this is a strong statement. It ends the debate, and now we consider after this trial that obesity is a major cardiovascular risk factor. This is first randomized clinical trial evidence. So my friends, in conclusion, obesity of BMI of more than 25 is the most rapidly increasing cardiovascular disease risk factors in the world. Many of them are declining. For example, dyslipidemia, hypertension, they are decreasing in the Western world, not in India. It is associated with downstream cardiovascular risk factors. That's why it is an important cardiovascular risk factor as overall, hypertension, diabetes, dyslipidemias. There are a number of biological factors, pathways, insulin resistance. Lifestyle is important. Novel drug therapies and bariatric surgery are important in obesity management. GLP-1 agonists have emerged as an important weight reduction. Drugs with randomized trial evidence, and what we consider now with all these trials is that obesity is an independent cardiovascular risk factor. Thank you.
Thank you very much, sir. Probably he has covered almost all the topic and the importance of the weight and reduction of the weight in cardiovascular outcome. So, as he discussed, that obesity is the important risk factor for cardiovascular diseases, and it was basically a debatable topic for obesity to be considered as a cardiovascular risk factor or not. I think he will agree that there was an inter-heart study that was done by Dr. Salim Yusuf a decade earlier, and that has also shown that the obesity and overweight per se was a risk factor for cardiovascular outcome. So my question to you is whether BMI should be considered as a marker to diagnose obesity per se, because BMI may differ. One muscular man who is liberal having good muscle mass and with a BMI of say 29 or 30, can this fellow will be considered as obese? So how to diagnose obese and how to categorize as an obese person for the risk factor of cardiovascular?
So obesity measurement is a very crucial issue. BMI is the most simple because you just measure weight, you just measure height, and it doesn't do the mathematics. So BMI is the most simple. The more useful is of course the abdominal obesity or the waist-hip ratio. But waist-hip ratio, there is a huge amount of variability. One person may measure a different way, the other person may measure a different way. So in the entire study, what we showed, I was part of that, what we showed was that abdominal obesity was more important than the total obesity. That means BMI, waist size was more important than as compared to the BMI. But I'll agree with you that BMI has a lot of fallacies, and one of the important fallacies is in the muscular man, you have high BMI with low fat and high muscle mass. Now, whether this is a risk marker or not, there are no prospective studies, by the way. Whether high BMI with more muscle has less cardiovascular risk, we don't know that, because recent studies have shown that athletes, at least the National Football League and the US athletes, have premature atherosclerosis at the age of 25, 30, at the age of 40, 50 years. So there is a follow-up of those people available. So I think it's a very difficult question, but I'll agree with you that BMI is not the best marker of obesity. The best marker would be multiple ways of measurement of obesity, and maybe with the emergence of AI-based technologies, we could measure one thing and then we can summarize that how much weight is a person has. But that's a future debate.
Can I ask you a question? You suggested about 5 drugs which are helping reduce obesity from 10% to 20%. And another way of reducing obesity is the lifestyle management with exercise and all. Are there any comparative studies of the two methods, number one? And number two, if you have to add a drug, maybe the recent one or the earlier ones, at what stage would you like to add the drug? It's a clinical question.
So yeah, I agree. Well, I think this was I think the part of clinical presentation here. There is no head-to-head comparison of lifestyle versus drugs, because all these trials, they at least say that we provide similar lifestyle advice to everyone. So you can't do that. So lifestyle on the one hand, lifestyle only, and drugs on the other hand, drugs only. You can't compare that because there is no head-to-head trial. But I think what we look at is they are all placebo-controlled trials, and in placebo group, they should presume they are advising lifestyle interventions, which normally people don't follow. There are lots of trials on lifestyle intervention follow-up studies. A meta-analysis showing that lifestyle interventions such as diet, exercise, meditation, everything reduces obesity up to a period of 2 years. And after 2 years, it tends to wean away. There was a trial in diabetic people, went on for 10 years, fundamentally analyzed, didn't show any benefit, lifestyle intervention. So these drugs are there to teach us. Now, when to start, there's a big question. People having diabetes, yes, they are good choices. Expensive drugs, still not feel available in our country. Lots of side effects, and the major side effect is nausea. You lose your appetite, and depression is also a side effect, and I think that's an emerging side effect. We have to be very careful of that. So nausea and depression are important side effects of these class of drugs. It is expensive, that's why it's not available in India, but I think right now the two indications are obese, diabetic, obese, cardiovascular disease. Now if BMI is simply more than 30, I will not recommend that. I will recommend first lifestyle. Maybe bariatric surgery is a better known with less side effects as compared to these drugs.
Good morning, sir. My question is that is there was any Society Cardiovascular Society of India to concern about the sudden cardiac arrest or silent MI, and any study done on it at present?
So next week there's this meeting of the Cardiovascular Society of India. So there is a sudden cardiac death council within the Cardiovascular Society of India. It is headed by Dr. Jadeva Institute Director. It is headed by the Jadeva Institute in Bangalore. And they are doing lots of work on sudden cardiac death prevention and early approach to management. So I think there is a society going.
Like sir, we all heard about that कि सिद्धार्थ मल्होत्रा ने सुसाइड कर लिया. Like we जैसे वो राजू श्रीवास्तव ने जिम करते करते अचानक हार्ट अटैक आ गया. तो पब्लिक में काफी यंग एज में हो रहा है, 40 के आसपास या 35 के आसपास, like 45.
Premature heart disease is not very uncommon. Was not very uncommon even previously. So I have done some presentation work on that. In the year 1990, from year 1990 to 2000, there were about 2.5 lakhs of preventive cardiovascular deaths happening, premature cardiovascular deaths happening in India. Those who died out. So that was between 1990 to 2010. Between 2010 to 2020, they increased by about another 10-15%. So now there are about 3 lakhs deaths prematurely happening in India. Whether COVID has increased it or not, we just tell you, I mean, there is a publication coming up in the Lancet, whether COVID has increased premature heart disease deaths or not. I can't tell you, I know the data, but I won't tell you because they are just coming up. But I think the premature disease is not uncommon. It is always there. It has always been there. And I think Himanshu will agree that we have patients of 20 years, 25 years, 30 years also, even 5 years, 10 years before COVID also, young people having cardiac issues. So I think it's not been uncommon. So only the thing is because the COVID has led to an increase in the health issues, and so that highlighted more.
Thank you, sir. Thank you. So I think intermittent fasting is probably important thing to reduce weight in comparison to total reduction of calories. I don't know, there are a number of studies. So I think Dr. Manjunath is heading this part of sudden cardiac arrest in young right now, in younger person.
Moving to another session, which is very important, related to the psychiatric aspects of the obesity. And we have with us very eminent psychiatrist, Dr. Shoaib. To chair the session, I would like to invite Dr. N. Saxena, Associate Professor, Department of Psychiatry, Mahatma Gandhi Medical College and Hospital. Dr. Munish Kakkar, sir, Professor and Unit Head, Department of General Medicine, Mahatma Gandhi Medical College and Hospital. Dr. Manjulata, Assistant Professor, Department of Physiology, AIMS, Patna. Dr. Ganashri CP, Associate Professor, Department of Physiology and Senior Instructor, ACLS, JR Trust of Karnataka. I request Dr. Shoaib sir to please come on the dais, and I request the chairperson to please introduce the speaker.
Good morning to all. I think there is no need to introduce Dr. Shoaib sir. He is a famous personality in psychiatric field and doing a lot of work nationally and internationally. And I am also a student of sir, and I would like to request to sir that deliver session.
Thank you very much. That I would like to thank my dear friend Ganesh, Dr. N Saxena. We studied together in SMS and we have lived our careers together, for very kindly inviting me to this program, along with Dr. Medhavi, the well-known nutritionist of the town. And I give my respect to the people on the chair. With that I start. I don't have to define obesity because you have been talking since yesterday what obesity is and what are the various comorbidities, including cardiovascular diseases, type 2 diabetes, hypertension, respiratory disorders, osteoarthritis, infertility, reproductive disorders and cancer. But apart from that, the important aspect is the various psychiatric disorders which we have with obesity. The prevalence of obesity, I am so happy that Rajeev has made things very easy for me. He has already talked about prevalence. 15 to 20% in the industrialized community. And obesity and abdominal obesity in Indian population. I came through the National Family Health Survey of not very old, 2019 to 21. The prevalence of obesity and abdominal obesity is 13.85 to 57.71%, which is almost close or a little more in certain geographical areas of the country. The abdominal or central obesity, which is waist circumference, is more than 80 centimeter woman and 94 centimeter in men. Factors which are related to obesity and abdominal obesity in our country are older age, being female, increased educational status, increased wealth index, being married at any point in time, and residing in an urban area. When we look at the ethnic groups, abdominal obesity is more common in residents of the north of the country, having a current alcoholic intake or even episodic excessive drinking. On the other hand, the obesity is more common in residents of the South India, which is generalized obesity. And targeting these high-risk groups can be a strategy for public health promotion and programs. At this moment, it would be very relevant to talk on the neurobiology of obesity. This is very important. Reason being that all of us as doctors should know about the reward system. I would like to remind you of the Skinner's box, an instrument which was designed by Skinner, a famous physiologist, who put one wire in the pleasure center of the hypothalamus and another wire on the pad of the Skinner's box. And he put a rat inside. And you know, rat has the tendency to jump here and there. And by chance, if the rat jumps on the peg, then his pleasure center will be stimulated. So he learns how to derive pleasure. And this would be a reward for him, and he will keep jumping and pressing the peg till the time it became unconscious. This similarly applies to reward system of food as well as the reward system of various drugs which are being consumed by various people, including alcohol. Wang and colleagues have done recent experiments on positron emission tomography, PET scans, to compare the concentration of dopamine D2 receptors in brains of extremely obese and normal weight individuals. And they found that obese individuals had significantly fewer D2 receptors than the normal weight individuals. I will request my dear friends to put off their mobile phones. I know today election results are very important for us. The entire nation is looking at them. But as a teacher, I would like to have eye-to-eye contact with whatever people are sitting here, irrespective of their seniority. I'm sorry. Then, obese individuals had significantly fewer D2 receptors than normal weight individuals. And among the obese individuals, the D2 receptor concentration declined as the body weight increased. So this is the effect of the repeated reward, that after some time the reward doesn't work. We know that dopamine is a pleasure seeking hormone which is produced in the body along with the serotonin. These findings suggest that overeating like substance use may initially stimulate the dopamine activity, but eventually leads to down-regulation of the dopamine receptors and a reduction in the dopamine activity. Overeating may thus be one of the several behaviors used to compete for the blunted reward effect of a hypoactive dopamine system. As I told you that the D2 declines after some time. If that is the case, the individuals examined by Wang and colleagues may have become obese because of a shortage of dopamine receptors rather than a loss of receptors because of overeating. Although there is an evidence for common pathway to obesity and drug addiction and lack of consistent association between obesity and substance use disorder, in epidemiological samples suggest that relationship between the two is complex. Now, if you look at relationship to psychiatric disorders, the clinical disorders, it is a bidirectional relationship. When one is obese, he has shame, he has body dysmorphic symptoms, he is worried about his obesity, he has anxiety, and then the symptoms which are symptoms of mental disorders in turn lead to obesity. So it's a bidirectional relationship. If you look at the biological mechanisms involved, inflammation, I will not go into the details. Dr. Rajeev has already talked about them. Endocrinism, insulin resistance, leptin resistance, SPA dysregulation. Then metabolism. These are the biological mechanisms which are involved in obesity, and that leads to unhealthy brain, neuroinflammation, neuroprogression, and neurodegeneration. So ultimately, people who are obese, they have a tendency of this unhealthy brain problem. Neurodevelopmental features, if you look at, then cyclothymic temperament. Some of the physicians may not know about this term. Cyclothymia is a condition where the individual at times is very happy and at times is very depressed, but within normal range. The cyclothymic mood continues. And this cyclothymia, when it increases to extremes, then it becomes a bipolar disorder like manic depressive psychosis. So cyclothymic temperament people who have, they have emotional dysregulation, executive dysfunction, and impulsive and addictive behavior, and that also has a bidirectional relationship, both ways. This leads to mood disorders. Then some children especially and adolescents have attention deficit hyperkinetic disorder, ADHD. And ADHD and mood disorders are also related to each other in the adulthood. That leads to eating disorder, and finally obesity. This is another hypothesis. So when we look at the behavioral dysfunction, poor self-control, poor self-regulation, amotivation, Rajeev was talking about the motivation and how to increase motivation, I'll talk about it later. Motivational disorders, counter homeostatic behaviors, they lead to weight gain because of excessive adiposity, so and so and so and so. That leads to neurobiological alterations like in the prefrontal cortexes. Our frontal lobe and the prefrontal lobe are the ones which are very important areas of the brain which are related to eating behavior. And people who have degeneration or problems relating to prefrontal and frontal lobe, they have a tendency to overeat. I will not go into the details of the various experiments like Clover-Bucy and other things which have been conducted in this area. So that leads to neurobiological alterations in the prefrontal cortices, hippocampus and hypothalamus. Hypothalamus on the top has the pleasure center, and once you have pleasure of anything, the release of hormones and circuitry is there, that comes to hippocampus and it goes back to hypothalamus, and that is the circuitry. That leads to neuropsychiatric dysfunction, cognitive functions are decreased, emotional regulation is decreased, and interoceptive awareness is also decreased. That leads to further behavior dysfunction. So that is how this cycle goes on in case of obesity. When we come to the psychiatric disorders per se, it is very important for you physicians to, I am giving you some carry home messages through these slides as to how you can probably look at your patients in the OPD as well. There is an association with depression and weight gain for women. Obese women are more predisposed to depression, and depression in women, especially later life, leads to obesity. Obesity also is associated with bipolar disorder and schizophrenia. Several second generation antipsychotic medication, antidepressant medications, and mood stabilizers, which we use in day-to-day practice, are associated with weight gain and increased risk for type 2 diabetes mellitus and lipid disorders. I will not talk about psychosocial factors, availability of food, socio-economic status, food intake, amount and pattern, what should be the diet composition, and how much should be the physical activity, etc. Rajeev has partly talked, and Dr. Medhavi is going to deal with these areas, so I have left it. Coming to the comorbid psychopathology, dysthymia, which is a low mood state running for a long time. These patients with clinically significant levels of depression should be encouraged to focus first on improving their mood before attempting to lose weight. As depression can interfere with treatment compliance, active substance abuse dependence is detrimental to weight loss success. So, any person for whom you are doing weight loss therapy, please ask them to avoid the substance use, including alcohol, various opiates, and other drugs of abuse. Binge eating. Eating too much at a given time is defined as loss of control while eating. A large amount of food in short period of time, which is defined by 3 or more of the following behaviors. 1. Eating rapidly. Why are you hogging? Why are you hogging? That is the question which friends ask when he is eating fast. Eating until uncomfortably full. Eating even when not hungry. Eating alone due to embarrassment and feeling disgusted, depressed or guilty about their eating behavior. This is what happens in binge eating. You do binge eating? Why your colleague is poking finger on your vest? Do you do binge eating? No. Do you observe her seeing as a binge eater? Please have some distance. Allow her to listen to me, okay? Then, the presence of binge eating disorder is associated with higher incidence of depression and anxiety. Okay? Then night eating. Some people have the habit of eating late in the night. They get up, sir, mujhe to raat ko bhook lagti hai. This syndrome is defined as morning anorexia and nighttime snacking with more than half of the day's calories consumed after the evening meal. Depression leads to loss of appetite. Unintentional weight loss are symptomatic of classic unipolar depression. But then depression has again a tendency of overeating in some patients. So it can be both ways. Some depressed patients eat more, some depressed patients eat less, and there could be a diurnal variation in these people. However, may display an increase in appetite and weight during the depressive episodes. Although the direction and magnitude of weight change varies between depressed adults. Bipolar disorder, when we talk about, I've already told you what bipolar disorder is. Individuals with bipolar disorder exhibit modestly greater rates of overweight and obesity. A comparison of obese and non-obese patients with bipolar disorder revealed that obese patients had significantly more manic episodes. Some people who are hypomanic and always on the go and do not care for eating and have a lot of energy, these people at times may lose weight. So that's a caution, a variation in presentation when we look at psychiatric patients. Obese patients also had poor treatment outcomes than non-obese patients when we treated them for psychiatric illness. Individuals with schizophrenia have been reported to have greater odds of being overweight also. ADHD and obesity, I have already talked about it. I will not go into the details of percentage, but 70% and 40% people have adults and children. 70% adults and 40% children have increased risk of developing obesity. There is an association in stronger adolescents, it's stronger in adolescents and in adults than in children, perhaps because of the ADHD's effect on obesity. It is gradual and does not fully emerge until full adolescence. Then eating and food addiction. This is another diagnostic entity which is coming, which is a part of the behavioral addictions. Behavioral addictions now, including internet addiction, screen addiction, this is another addictive behavior which is coming up, and shortly, maybe 2-3 years later, you will find it as a diagnostic category in the DSM-5 or the later versions. Some kinds of food can become addictive in susceptible individuals. More precisely, the food addiction hypothesis can be conceptualized as a twofold postulate. Number one, on the one hand, it states that there exist certain individuals who develop a behavioral syndrome characterized by craving for food and loss of control over eating in spite of its known detrimental health effects. So, जानता है कि मुझे इतना नहीं खाना चाहिए. Despite that, he cannot control himself, which is quite similar to classic behavioral addictions, and therefore eating addiction term is coming up. On the other hand, it claims that some specific foodstuffs, namely high-calorie, sugar, fat-rich foods, can activate the reward system, which I explained you earlier in my talk. It activates the reward system as classic addictive drug, and that becomes food addiction. Although a recent systematic review of it concludes in favor, it is necessary to point out that food addiction construct is still much controversial and represents a thorny subject in the current specific debate. So people are still debating in the scientific fraternity. So caution is needed when addressing this problem, given that its precise boundaries are not well defined, especially regarding the similarities and differences than other and more established forms of addiction. The prevalence of food addiction in an Italian study, there are no studies to the best of my knowledge in our country. Obesity, people with obesity is highly variable from 7.7 to 47%. Possibly depending on the weight, excess severity, there is a scale which measures the severity of the food addiction, and on that scale it was measured, but seems to be consistently higher in females and older people. According to that Italian study, cross-sectional study, food addiction measured by Yale Food Addiction Scale, it was found nearly 34% of the patients seeking treatment for obesity, while a recent German cross-sectional study found that 27% of the people had prevalence of food addiction in bariatric surgery candidates. Now, very important question for you physicians. All of you prescribe antidepressants in varying doses. Sometimes homeopathic doses, sometimes adequate doses, sometimes higher doses. But all physicians, I will not go on the survey of prescription writing epidemiology of various categories of physicians. I have done a study on that. And I found that psychiatrists are number 5 in prescribing in their prescription antidepressant and anti-anxiety drugs. Highest being the gastro and second being the cardiologist. That is the state of affairs. So you have to be very, very careful, and please do give some attention to next 5 slides. Several of these drugs now known to be associated with weight gain. And these include the atypical antipsychotic medication, antidepressant medication, tricyclic antidepressants, mirtazapine, and mood stabilizers, including lithium and some anticonvulsants like sodium valproate. What are the second generation antipsychotics, which I am talking about? Number 1 is clozapine. Clozapine has very high tendency of weight gain. Risk for diabetes, yes. Worsening lipid profile, yes. So every patient whom I prescribe, I do essential first line test, the CBC, lipid profile of these patients, ECG, and blood sugar. These are the 4 tests. If anyone sees my prescription, you will find on every first prescription which I have, so that on follow-up and I can find it out. Then olanzapine is another notorious drug, which is very good for treating psychotic illness, but we are giving combination, many of you in olanzapine plus fluoxetine and so on. But it's a notorious drug for weight gain, again risk for diabetes and worsening the lipid profile. Quetiapine and risperidone have lesser tendency of weight gain increase, and aripiprazole and ziprasidone plus minus. So safe would be aripiprazole and ziprasidone if you are really treating an obese patient with psychotic illness. Type 2 diabetes mellitus and dyslipidemia. People suffering from schizophrenia have greater likelihood of developing obesity and diabetes. Some of the antipsychotic medications, however, have a greater likelihood of being associated with the development of obesity and type 2 diabetes mellitus and lipid disorders. Lipid disorders also are associated with the weight gain found with the use of second generation antipsychotics, which I described in the previous slide. The greatest increase in low density lipoprotein, cholesterol and triglycerides, and reduction in high density lipoprotein HDL are found with the most weight gain people, especially in those treated with clozapine and olanzapine. Aripiprazole and ziprasidone appear to have minimum weight gain effect and dyslipidemia. Once second generation antipsychotic treatment is started, the weight of the patient should be taken at week 4, week 8 and week 12. And you must see what the chart says. If the patient has gained more than 5% of the initial weight, consideration of switching to another second generation antipsychotic should be considered. Fasting lipid profile and glucose along with the blood pressure measures ought to be made also at 12 weeks if you have treated the patient for 3 months. These may make quarterly and appropriate referral to other healthcare providers like you for taking care of their hypertension, dyslipidemia, hyperglycemia and symptoms of diabetes and chronic DKA should be made clinically indicated. There is some initial short-term evidence that adding a dietary and physical activity, which Dr. Medhavi is going to talk about, as intervention may minimize the weight gain with the SGS, and more research is needed to evaluate the effectiveness of this strategy. Antidepressant medication. We all prescribe antidepressants because depression is so common a modality. With all your chronic, sir, all chronic physical disorders. बाद में कर लेना यार, बात बहुत देर लगेगी लगातार लगा हुआ बाद में कर लेना बेटा. Listen to me. You will not have me to talk to you again recently. Okay? So when you prescribe antidepressant medication, or if there is something urgent, you can walk home. You have the option. Some antidepressant medication also have been associated with significant weight gain. You must understand this. Treatment with the antidepressant requires attention, not only response to treatment for depression, but also attention to increased weight gain and BMI. It is recommended that weight and BMI be monitored with antidepressants. Use of antidepressants that are associated with minimal weight gain, especially in those risk of high obesity. Switching to another antidepressant when weight gain occurs will be required. So what are the weight neutral antidepressants? That is the most commonly asked questions to me in various lectures which I give to the physicians. Selective serotonin reuptake inhibitors, SSRIs, usually have fewer side effects including weight gain. And these are fluoxetine, sertraline, citalopram, citalopram, paroxetine. When you do a comparative study of these molecules, more or less, they have similar effects. Other antidepressants that are less likely to cause weight gain include bupropion and trazodone, which are slightly older generation than SSRIs. Lithium treatment has been associated with weight gain. When you talk of mood stabilizers, you have two categories. One lithium, and second is divalproics and sodium valproate combination. the weight gain with lithium and valproate are significantly greater than with topiramate when it was used. Okay? Lamotrigine increasingly becomes used as a mood stabilizer, and it has not been associated with weight gain. Coming to the behavioral treatments, what Rajeev indicated when he was closing the session, behavioral treatment for obesity generally include three components. One, dietary change. Two, increased physical activity. And three, behavior therapy techniques such as goal setting, self-monitoring, stimulus control, and behavioral contracting. These are established therapeutic techniques in the psychiatric treatment procedures, which are well-known behavior therapies for weight reduction. In addition to weight loss itself, a goal of behavioral intervention is to introduce lifestyle change as increase in the likelihood of weight loss. A typical behavior weight loss program includes 12 to 16 sessions over a specific strategy, such as recording daily food and calorie intake, avoiding triggers for unhealthy eating, increasing physical activity, obtaining social and family support, and modifying thoughts and emotions that undermine the weight loss. Behavioral interventions generally result in weight loss about 8% to 10% of the initial body weight. Prevention and treatment programs for patients with bipolar disorder might include behavioral intervention for weight management and use of combination and pharmacotherapy with medication that might reduce weight loss. That is why I asked that question to Rajeev, that these weight loss, some people, about 3 years ago when I was in the World Congress of Psychiatry and APA conference, there was a question, am I a psychiatrist or am I an endocrinologist? With the recent event of the drugs which have come up in psychiatric treatments. So, mood stabilizers are important for managing bipolar disorders. The psychiatric status of patients with these disorders needs to be considered before switching medication because of weight gain to minimize the risk of destabilizing the patient's psychiatric condition. Coming to the summary of the whole thing which I have talked, many genetic, environmental and behavioral psychological factors they intersect to increase the risk of someone becoming obese. In assessing the patients with obesity, however, a supportive, non-judgmental and sensitive approach usually leads to best result in most complete information. Relative to treatment, the options vary depending on the severity of obesity and presence or absence of obesity-related comorbidities. So with this I close my session. This is the institution where I am working after my retirement from the SMS Medical College, where I developed the department which most of the professors of psychiatry in the state and even outside are my students. Some of them have retired. Being an old teacher, I have a tendency to keep an eye on all my students. Please forgive me for indicating you, but it was important. You will realize it later. It is important. Because psychiatric issues are not discussed in many of the medical conferences, and it is thoughtful of Ganesh to have given me this opportunity. And thank you very much, chairpersons, ladies and gentlemen.
Thank you, sir. Excellent delivered a lecture on the psychiatric aspect and obesity. And sir pointed out that bi-directional relation, like obesity and mental health. कि अगर एक डिप्रेशन का पेशेंट है तो भी ओबेसिटी या ओबेज होगा या वेट गेन होगा, और अगर लाइक ओबेज है तो भी डिप्रेशन में आएगा. Very important. Thank you, sir.
No questions? Give you two messages. Either not understood or very well understood. So, I take the second one for my help.
Sir, I want to ask one thing. Sir, I want to ask one thing.
You want?
Yes, sir. Actually, sir, psychiatrist is facing a lot of stigma and challenges in psychiatric field in India and I think internationally, or India and Rajasthan more and more. So is there any solution for that?
There is a solution. When I started my career way back in 1979, people used to come and tell me कि डॉक्टर साहब हमें शाम को देखिएगा थोड़ा सा अंधेरा होने के बाद, जहां मैं देखता था उससे आधा किलोमीटर आगे जाके कार पार्क करते थे
राइट,
और चुपचाप देखते हुए आते थे कि डॉक्टर गौतम के पास जा रहे हैं, कोई हमें देख नहीं है. That was the state of stigma. And now you will find a queue of 150 people in my OPD with all categories of people. All categories of people.
yes,
IAS, ex-IAS, very good socio-economic status people and rural people as well. So last 50 years we have worked hard in Indian Psychiatric Society. This stigma has definitely decreased. You have to develop yourself to be competent to answer the question of your patient.
yes.
That is the only way. Thank you.
Thank you. Thank you.
Yes, Rajeev. Motivation. The motivation enhancing therapy, NET, is a proper treatment procedure with 12 sessions. It is broken in different steps, and we train all our clinical psychologists for using MET for drug addicts as well as the obese patients. That is one technique. Another is the behavioral contracting technique, which I have described in one of the slides. We are a training center for mental health professionals also in the private sector. We are training clinical psychologists, we are training skilled workers, we are training nurses, and in the last 10 years, it has become a very good mental health professionals training center as a second institute in private sector. So if you have any psychologist, you can send them and we will train them in about 2 months' time. Thank you.
There's one more thing I would like to add, Dr. Rahul, that is with reference to his question.
Yes.
That why is the stigma getting less when it is important? Some major film actors also acted as a role model.
Deepika Padukone,
yes, who have come out
when
with
she
illness.
suffered from depression, she did not hide. She said, I suffered from depression. I am getting well. And fortunately, I am still the chairperson of the Clinical Practice Guidelines Committee of Indian Psychiatric Society. We are producing one book every year, which most of the psychiatrists in the country, they have on their table as a guideline book. And when one of the programs she came, and I interacted with her, she said, why people hide their depression if they don't hide the diabetes, if they don't hide the hypertension. So when we will come with some of the role models like this,
that is one of the reasons.
and when we share the success stories of my patients, in the Mental Health Week, which is celebrated every year from 4th to 10th of October, I have at least 3 to 4 treated success cases who tell their story, how they have recovered and how they have become RAS, IAS, how they have become successful businessmen, and they motivate other patients. So this could be another way of reducing stigma. Stigma reduction is a 1-hour lecture in itself. So I'm sorry, the time is less and I'm encroaching on Medhavi's time. So I think we can stop here.
Session. Now I would like to invite Dr. Medhavi Gautam for the next talk and request our chairpersons to please introduce the speaker.
Good morning, one and all. Yes. It's my pleasure to introduce our speaker, Dr. Medhavi Gautam, who has a work experience of 19 years. She has done a PhD in food and nutrition, and right now her designation is she is a dietitian and consultant dietitian as well as nutritionist. She is director for Dr. Medhavi Nutrifit Jaipur, and she is a joint secretary IDA Rajasthan chapter. So coming to her achievements, there are so much, starting with the Venus Inspiration Women Award in the year 2022. She's felicitated the Jewel of Rajasthan Award in 2022 for excellence in field of nutrition and dietetics. Felicitation for ongoing commitment and dedication in the field of nutrition, Shakti Swarupa, 8th March 2022. Felicitation for endless commitment towards the society by Jaipur Moms Group on the occasion of Doctors' Day in July 2021. Felicitation as Corona Warriors on International Women's Day by Akhil Bharatiya Thirapanth Mahila Mandal 8th March 2021. Felicitated Rajasthan Gaurav 2020 for excellence in the field of nutrition and dietetics January 20th. Swaran Padak Award in Annual National Conference of Dietitian in the year 2018, and many more to add on to our feathers. And she's been invited as speaker in more than 980 lectures, as well as in TV shows, FM and air. She's the author of book Count Your Calories, and she's trained more than 300 dietitians across the globe. Thank you.
Very good afternoon to, very good morning to all of you. It's still not done. And thank you very much to Saxena sir for inviting me here. It's an honor to be in front of these stalwarts here, Rajeev Gupta sir, Dr. Gautam, and many more. I'll be more of talking about I'll not discuss about what obesity is and all that, because we have been talking about obesity since yesterday. Body mass index and waist-hip ratio. These are the two things which Gupta sir has also touched, and we have to understand that body mass index alone can never be an indicator for obesity anymore, because there are many instances where body mass index is normal, but we have other metabolic disorders also, and they are then considered in the same case. So waist-hip ratio is more relevant in Indian context, because we know that the abdominal obesity is maximum here, and especially in the women. When I talk about the types of obesity, the term of adiposopathy clearly defines the pathogenic role of adipose tissues. 4 phenotypes of obesity have been described and based on the body fat composition and distribution. So that's distributed as normal weight obese, where they are obese, seeing their BMI. Then there's metabolically obese normal weight people where the BMI is normal, but they have got the metabolic disorders components in their their insulin resistance is poor, or the lipid profile is deranged. Then we have metabolically healthy obese, where your metabolic profile is good, but the BMI and the waist-hip ratio are deranged. And then we have metabolically unhealthy obese. They are clearly obese, more than 30 BMI, along with all metabolic disorders. Causes of obesity are definitely not unknown. The major cause definitely is the lifestyle disorder, lifestyle changes, where prominently it is the diet, where your energy intake is always more than the energy expenditure. Then second is the behavioral factors like physical activity, diet, eating patterns. Genetic factors cannot be ruled out. Medical factors, endocrine disorders, medications, and then others are like aging, smoking, and pregnancy. Stress definitely is one of the bigger factors now, seeing the scenario in today's day. Susceptible age groups are children where both parents are overweight and obese. Socially deprived groups and those with low income groups also have obesity. In today's date, when you see in most of the rural areas, you will not find good fruits to eat. You will not find good vegetables to eat. The eating pattern there is like this, that they will have roti and some little amount of vegetable or something. But you will definitely find a packet of kurkura there. You will definitely find a shop selling some cold drink there. So that's the impact, where we can say that these are the factors which are also influencing the rural population. It's not that obesity is just in the urban population. We get to see people from the rural population as well who are equally obese. And level of education definitely impacts on the behavior therapy of the patients and people with learning difficulties also. So is obesity a public health problem? Definitely it is. Sir has already spoken about that how obesity is can impact greatly with the NIDDM, gallbladder diseases, dyslipidemia, insulin resistant, breathlessness, sleep apnea. Then can again moderately increase the CHD, hypertension, osteoarthritis, hyperuricemia and gout. And also there has been an impact on cancers, specifically breast cancer, endometrial colon cancer, polycystic PCODs, PCOS, impaired fertility and back pain. What are the obesogenic environments? Energy intake, definitely the dietary behavior and patterns are there. Affordability of food, that's again a very big factor where obesity, because in our, I would not talk about the country, I will specifically talk about state also. The general eating pattern in our population is that khana matlab roti sabji. That's basically khana. If we take the 24-hour recall of any patient who is coming to us and we ask what is your eating pattern, how do you eat and all, so sab 4 roti subah khai, 4 roti sham ko khai. So roti is basically the prominent thing which happens to be a part of diet. So basically the diet is more of carbohydrate based. There is no dal liye to liye, sabzi liye to liye. That's how it is. So basically khana is in the Indian context, food means roti. So we are prominently carb based eating people. And eating out is a very common thing. Weekend parties is a very common thing. Socializing, I do agree, we need to socialize, but every time to eat out and socialize, that concept has gone quite high. Convenience foods, everything is on your availability. And now the best part is you have these online apps. COVID ke baad mein, we have everything on one finger tap. You have Swiggies, you have Zomatos, you have everything on your one finger tap. So you don't need to go out and eat. Everything comes to you conveniently at home also. Desserts, we are as Indians happy to eat desserts because desserts give us happiness, but yes, that happiness costs us a lot of things. Now then, second hand is the energy expenditure, physical activity. That's again one thing in common wherever we ask somebody that do you have a habit to go for a walk daily? Here also if I randomly ask, okay, how many of you, being doctors, we are the worst people actually, but how many of you actually daily go for a good walk? Daily. So these are just couple of hands which are here out that we daily go for a walk. And how many of us are, because walking is the basic and simplest exercise we can think of. I'm not asking about Zumba and aerobics and yoga sessions and all. It is simple as just going for a good walk. And nowadays the fashion is to count your steps. So we are not doing even the basic of the exercise. And this is us who are actually treating patients. Now what about the general population? Walking and physical activity is always taken aback whenever it is seen. It is only when we have some kind of disease, doctor asks us to do a lifestyle management, then we think कि नहीं अब तो walk भी जाना है, अब तो exercise भी करनी है, weight भी कम करना है, just to get my lipid profile normal, just to get my sugar levels normal, then I will think about going for a physical activity or a lifestyle change. Otherwise, no. So that's it. Anywhere I have to go, even in smallest to smallest place, bike उठाया और चले गए. So that's how the people, you will, एक पास के चाय के दुकान पे के जाना है ना, nobody will go by walking. They will take their bike क्योंकि उसके बाद कहीं और हम लोग घूम घाम के आ जाएंगे. But that's how it is. So it's that convenient. Desktops have increased, TVs, your internet and the mobiles, they are the biggest culprits that stop us. And especially I would say the social media. The younger generation will know how you are stuck up to the Instagram, how you are stuck up to the Twitters and all, that you don't even realize how you have gone up an hour and the time has gone. हम ये नहीं सोचेंगे कि हमारे पास free time है तो we go for a good stroll with our friend. Probably we will use our phone and send reels to our friends and that will be a better communication, right? Am I right? When we talk about the smaller errors in energy balance and biological maintenance, so what happens is every time when we gain weight, so weight gain is not a very, ऐसा नहीं है कि एकदम से we have suddenly gained weight. It's never like that you have 3 kgs up, you're 5 kgs up, unless that there's some hormonal disorder or some other thing. An average discrepancy of 10 to 20 kgs, 10 to 20 kilocalories per day between energy intake and energy expenditure, that is 0.5 to 1 kg. Weight gain every year happens in adult life. So that's an average thing. 10 to 20 calories is nothing when you see. 10-20 calories के बारे में कौन सोचता है? I mean, when we take even a packet of chips, so we are consuming almost 100 plus calories and we don't even mind about it. So 10 to 20 calories is nothing per day, but that is almost 1 kg weight gain every year. And what happens is, it is then converted to the biological maintenance. हमारा body जो है उसकी धीरे-धीरे maintain करना start कर देता है. तो होता क्या है? Well, you gain this 1 kg. As the weight gain occurs, the resetting of neuroregulatory system happens, and so the extra weight is a new normal by default for our weight settings of our body. So, ये 1 kg becomes a new normal for the body. So, if I am 55 and if I am 56 by the end of the year, 56 is my new normal for the body, and we will not realize that this is a kg's gain. What happens is that जब ये 56 से 60 पे पहुंचता है ना, then it is alarming कि अरे how I've come to 60 kgs, I don't know. But this happens every time, and that happens from very smallest thing is to see the calorie check. So there was a question that how are we going to see कि patient कर रहा है कि नहीं कर रहा है, and how do we do it? So there is a 3 E's model, and this is a quite old model. Mayer and Davis in 2003 proposed this simple 3 E's model. Whenever we are counseling a patient, there are 3 steps we have to counsel the patient or to motivate. The first step is the encouragement. That refers to simple exhaustion to persuade the individual to change their lifestyle. For example, to eat lower energy foods or to take more exercises. So this is first. You have to encourage the person, yes, you can do it. 10 kgs is not a big thing. Or in case if it is even 30 kgs, we have to set realistic goals. That is, every month we have to lose 2 kgs, 3 kgs, which is again not a very big thing. So 30 kgs we can easily lose, but that will be 10 slots, or that's how you counsel. So it's like you have to encourage the person first. Sorry for this, I have a bad throat. So you have to encourage, that's the first E. Second E is the empowerment. That you have to make the person understand. This refers to the process of providing knowledge and skill in educating the life skills to help the individual to make a healthful changes. That will be an educational approach. We have to tell them that these are the things which can happen to you in case you don't now come to a healthy lifestyle. Thank you so much. And these are the things, so we have to show them both the sides of the coin. One, that these are the things which can go worse, and these are the things we can stop, and we are not that bad also, that we can't go ahead. So that's how it is. So we have to tell them this. And this might include the awareness of basic nutritional principles, food shopping skills, that what you have to take, grocery shopping kya hona chahiye, cooking skills, building confidence and self-esteem. So these are the points where we have to cover when we are empowering the patient or empowering the person to lose weight. Third is the environmental change. Third E. That refers to the totality of cultural, social, physical, economic environment required to facilitate the improvements in lifestyle factors such as diet, physical activity, sleep, stress, and many other things. Now when I am talking about lifestyle, again and again, one thing which is very prominent is diet alone can never help anybody to lose weight. That's one thing which I tell each and every patient of mine who come to me, that whenever you are talking about a lifestyle change, it has to be all 4 factors together: diet, exercise, sleep, and stress. Stress has been quite well covered by Gautam sir, but you have to understand that your sleep, you have to make the patient understand that your sleep is also equally important when you're talking about obesity. Why I want to touch about sleep is because this is one thing which is going haywire in every sector. We are sleeping late, getting up late, or we are sleeping in odd hours of time. People understand that you have to have a 7 to 8 hours sleep. That is very important. But what time? That's equally important for a person to understand. That you have to have a good sleep between 10 p.m. to 6 a.m. And that's where we don't actually do. We go to bed normally around 11 or maybe 12. Maybe it can be 1 or 2 also. And then accordingly we set our 7 hours. If I'm sleeping at 1, I might get up at 9 o'clock. I might get up at 8 o'clock. मेरा 7 घंटा हो गया पूरा. In case I have a lecture to attend, I can't sleep late. तो मैं आके पूरा कर लूँगी. But I'll have a 7 hours sleep. Sleep की जब भी मैं बात करती हूँ, we are all known of this term called as circadian rhythm. All of us know about it. Sorry. So that's basically our nature cycle, which we have to see according to our own body cycle. We have to match that. So circadian rhythm is from the sunrise to the sunset. And the best part is that the body also produces hormones according to sunrise and sunset. The first hormone in sunrise, what body produces is serotonin. That's a happy hormone. Also, it helps you. That's why it is said that when you go in the morning, rise up early in the morning, go for a good walk. So you have this happiness in you. You know why? Because serotonin is there on rise, and it is helping you to keep happy. By the end of the day, when the sun sets and darkness, that helps, that actually regulates the another hormone, that is melatonin, which is very commonly known as a sleep hormone. Why? Because again, melatonin helps you in a better sleep in those hours. So we have to set our cycle according to sunrise and sunset, and that helps in a better sleep. Sorry again. Thank you so much, sir. So we have to set our cycle according to the circadian rhythm. We can't disturb that rhythm. That's the nature rhythm, and that's why you can see the difference in the lifestyle and the weight maintenance of people of our Dadi Rani's age and of us. You know, you can see the clear difference. Why? Because then it was always the circadian rhythm. My Rani used to have her dinners by 6-7. Now, intermittent fasting is quite in good fashion, and that is exactly what our ancestors used to do it, and that's exactly what the circadian rhythm says. That you have to end your day with the sunset. That's how exactly it comes. So that's why only diet is never important. It is the diet, it is the exercise, it's the sleep, and to control over the stress levels. When I talk about a dietary management, it is the cornerstone of weight loss therapy. Most of the dietary regime proposed for weight loss focus on energy content and macronutrient compositions. It is necessary, it is the energy content that determines the efficiency of dietary regimes. Obesity treatment guidelines issued by the NIH recommend that persons who are overweight or who have class 1 obesity, who have 2 or more risk factors, should reduce their energy intake by 500 calories per day. Person with class 2 and class 3 obesity should strive for 500 to 1000 kilocalories reduction, with the reduction of 500 kilocalories of energy intake. A weight reduction of 0.5 kgs per week can be achieved when you are just reducing by 500 calories. 500 calories means like every meal you can reduce by 100 calories. So like cutting down on one roti. So that's not a very big thing actually. So cutting down on one roti and cutting down on your sugars and obviously the fats will help you in losing 500 calories in one day. These are the type of diets commonly used when we talk about weight management. The low calorie diet, which are high in carbohydrates, that's 55 to 60%, low in fats, that's less than 30% of energy intake, high in fiber and have low glycemic index. Alcohol and energy dense snacks should be avoided in LCD. Then low fat diet, these diets reduce the daily intake of fat to 20 to 25% of total energy. For persons with 1500 calorie diet, this translates 30 to 37 grams of fat, which can be counted using food label packages. Food labeling packages is again one important thing that we have to understand how to read the food labels, because that's where actually the content of carbs is written fats is hidden, and specifically the trans fats and the SFAs, which even Rajeev Gupta sir specially highlighted on. Low carbohydrate diet, the carbohydrate content of the diet is about determined on short term, that is less than 2 weeks weight loss. Low carbohydrate is 60 to 150 grams of carbohydrates per day. Very low carbohydrate diet is around less than 60 grams of carbohydrate. That's been very popular in many years these days. And even one thing which has been very popular these days is to cut down on gluten or be on a gluten-free diet. But normally as a nutritionist we don't recommend that you have to. These are not fad diets, may it be a keto diet, may it be a gluten-free diet, because these are all shortcuts to weight loss. Anytime if somebody is approaching you that I can do this or that for a weight loss, these are all shortcuts because they have their own health hazards when followed for a very long time in your diet regime. Then very low calorie diet, which is normally not prescribed. This should be always under the supervision of an expert. These diets, the energy content is 200 to 800 kilocalories, which is actually not to be prescribed unless that it is, and some serious severity is there. Diets below 200 calories per day are starvation diets. VLCTs are not recommended for general use. There are significant adverse events such as electrolyte imbalance, low blood pressure, increased risk of gallstones. So these are not recommended VLCTs. They are just recommended for a very short period of time for morbidly obese patients who might go for a bariatric surgery further. So there is the time where VLCTs are used. Otherwise, this is not recommended. So it's never to be given in general. I talk about now carbohydrates specifically. These are the two macronutrients which I am touching, the carbohydrates and the fats, because we are talking about obesity right now. Among the carbohydrates are the macronutrients that provide energy and can thus contribute to excess energy intake and subsequent weight gain. The quality of carbohydrates rather than the quantity determines whether the person gains weight or becomes obese. The quality is always important. आप कितना खा रहे हो उससे ज़्यादा important है आप क्या खा रहे हो. So what type of carbohydrate it is? It is a simple carb, it's a complex carb, because carbs is carbs, and we have to understand sugars is a carb, and a bran roti is also a carb. So we have to see the quality of the carb. Is it a sugar? We have to consume. Sugar means just not the sugars. All kind of sugars comes in, and or we have to have a fiber-rich thing. The high glycemic index food causes sudden increase in the blood sugar, and this increased blood sugar, if not utilized by the body, builds up on the fat. Now I talk about the fibers as carbs. So a fiber-rich diet is important to control and for the management of weight. Fiber is mixture of cellulose, lignin, and polysaccharides called as pentoses. It is the part of plant food which is indigestible and does not provide any calories. So fiber helps in management of obesity as it provides bulk to the food, which makes you feel fuller for a longer time. Satiety levels improve karta, and it also helps in reducing the calorie consumption. So that's why it is always said कि आप अच्छे से salad खाओ. If you consult a dietitian, the first thing which come on your platter would be a plate of salad before you eat food. That's the only purpose, that it increases bulk, it increases the satiety level, and that helps in the reduction of your total calories. The high fiber not only helps in losing the weight but also prevents heart diseases as it reduces the absorption of lipids, proteins, and simple carbohydrates, which are recognized as risk factors. Certain pentoses present in fiber bind the cholesterol, thus reducing the absorption from the intestines. Daily intake of 10 to 12 grams of fiber is recommended. Fiber-rich food includes wheat bran, whole wheat flours, peas, carrots, and most of the leafy vegetables and your salads. Fiber to carb ratio is 1 gram of fiber for every 10 grams of carbohydrates. That's very important. So 10 gram carbohydrate पे 1 gram. So हम सोचते हैं अगर हम कि 500 हम लोग 200 grams carbohydrate लेते, that means you need minimum 20-25 grams of fiber in your diet. That's how it is. Now I talk about fats in the obesity. That's the second macronutrient which we have to understand. Excessive fat turnover and oxidation might cause insulin resistance and carbohydrate metabolism in obese humans. Weaker satiety signals from fat can form. Carbohydrates and proteins have suggested to play a role in overconsumption of energy from the fat-rich diets. So जब भी हम आप देखो जब भी आप घर में पूड़ी हलवा या दाल बाटी ये सब हम खाते हैं, so we feel full at that time, but consecutively you feel that you need to have something more after some time because fat से आपका taste increase हो रहा है, fat से आपको मज़ा बहुत आ रहा है खाने में, but fat will not help in satiating you. So whenever satiating or satiety levels are concerned, we have to understand जब भी आप पूड़ी हलवा खा, don't say not to have पूड़ी हलवा, not to have दाल बाटी, but before that always try to have a platter of good fibers in your diet, and you will see in response, if we see the blood sugars also, you will see in response that the blood sugars are well controlled even after having all these things. So that's how we can see that how fat and fiber keeps it. Fatty acid composition of the diet may play an important role in body weight regulation and cellularity of adipose tissues. Epidemiologically, studies have shown that a positive relationship between the dietary fat intake and obesity. Saturated fats are more obesogenic than the PUFAs, polyunsaturated fats. The obesogenic effect of saturated fatty acid can be explained by the fact that SFAs are poorly used for energy and so remain to be acylated into TAGs and stored in adipose tissues, whereas PUFAs and MUFAs are readily used for energy and not stored in the tissues. So that's how it is कि आप कितना saturated fat consume कर रहे हो कितना. So we don't say not to have ghee. आप घी मत खाओ ऐसा कोई भी नहीं कहता. We have to see the proportion of how much of SFAs and PUFAs you are having. The proportion is 1:2. So if you are having आपके पास में इतना हमारा एक दिन का fat content मैंने सोचा है कि I have to have 30 ml of fat in a day. So then it will be 10 ml of ghee and 20 ml of your oils and seeds and all that. So that's the proportion. So आप खाइए, but you have to see the proportion, how much of SFAs you are consuming and how much of PUFAs and MUFAs you are consuming. Saturation of fatty acid decreases their suppressive effect on dietary intake. Thus, fats and oils containing high proportion of linoleic acid are more satiating than fats and oils rich in oleic and stearic acid. For example, आपका peanut oil हो गया, soybean oil हो गया, sunflower oil, these are higher in the linoleic acid. So those will be better in consuming it than the other oils. PUFAs inhibit the appetite more strongly than MUFAs and SFAs, and through an increase in the release of cholecystokinin, which augments other signals of satiety. तो इसीलिए आप PUFA लेते हो, आपका PUFA का कंटेंट अगर ज़्यादा होता है डाइट में, तो ये भी आपको हेल्प करता है satiety levels को बढ़ाने के अंदर, instead of taking more of SFAs and MUFAs. Now I come to the micronutrients in obesity. So we always talk about the macronutrients, we talk about the fats, we talk about the sugars, the carbohydrates, but we talk about proteins also, but we never touch the micronutrients because they are equally important when you are talking about. Obesity is violation of carbohydrates and fat metabolism, which further affects the micronutrient status also. The volume of distribution of your lipophilic substances, including fat-soluble vitamins, also increases the proportion of fat mass. So obesity leads to the decrease in vitamin D, and that's an endogenous synthesis. The development of vitamin A and vitamin D deficiency aggravates the carbohydrate and fat metabolism. And vitamin A, that's a vicious circle, that increases the carbohydrate and fat metabolism, and that leads to weight gain. Weight gain leads to again deprivation of vitamin D, and that's how this goes in. Then obese people are at greater risk of developing zinc, manganese, magnesium, chromium and vanadium deficiency. This is due to the increased need of these elements in obesity because they are involved in carbohydrate and fat metabolism both. So we need to be very sure that we are taking enough of zinc and magnesium and in diet wherever we can get it from. We can get it from seafoods or from nuts, from whole grains, from breakfast cereals, dairy products. That's how we can suffice these requirements so that we cut that vicious cycle. Also, I would like to highlight on the antioxidants in obesity. Now, stress is one of the biggest reasons of obesity, which has been dealt by some. Antioxidants is always proven a right choice whenever this oxidative stress is happening, and obesity is one place where oxidative stress is rise. Emerging research's evidence indicates that natural antioxidants can modulate the oxidative stress, improve immune functions in obesity, and thus the role of natural antioxidant compounds in the prevention of treatment of obesity-related diseases is seen. Oxidative stress has been reported to be linked with several metabolic diseases such as obesity, diabetes, hypertension, dyslipidemia, and chronic exposure to elevated glucose levels, triglycerides, and free fatty acids. And these seems to activate the oxidative process. Evidences indicate that antioxidants could play a key role in positively modulating hormones, neuropeptides involved in appetite, satiety, and regulation of energy expenditure. So that is why antioxidants come in here. Homeostasis, leptin and adiponectin from adipose tissues, insulin from pancreas, GLP-1, granule, PYY, CKK, and from the gastrointestinal system, creating a less obesogenic propensity. So antioxidants equally play an important role. When I talk about natural antioxidants, there are three natural antioxidants which we get from diet. They are vitamin A, C, and E. That's one thing which we don't have to, have it from outside. In case we have a proper lifestyle, proper habit of eating these antioxidant diet. And when I talk about these three antioxidants, we have to just remember 4 colors actually. 3 colors are your traffic lights. That's red, green, and yellow. These are the 3 colors which you have to actually tell patients that these are the colors which should be on your platter, on your daily platter. So it's not that one plate you have to have all these colors, and one day's meal you have to have all these 3 colors which are rich in vitamin A and vitamin C. For vitamin E, we have nuts and seeds, that we have to have a handful of nuts and seeds daily, which can be anything: almonds, walnuts, your seeds, flax seeds, sunflower seeds, or any seed which you can want to consume. So these are and the 4th color is your white, which is again vitamin A retinol, which can be your milk and milk products and your eggs and all. So these are the 4 colors which we have to tell people that you have to consume on a daily basis to have a good antioxidant dose. Curcumin is one more thing which has been quite researched and very helpful. Curcumin is nothing, this is haldi, hamara ghar ke khane mein, which we normally use. Curcumin is a polyphenolic natural compound contained in Curcuma longa, a member of ginger family, and consumed as a spice also have an anti-obesity effect. Just 2 minutes. Preventing the pre-adiposity differentiation, reducing the negative health effect of obesity. Curcumin supplementation has also have significantly shown a reduction of BMI and waist circumference in people with fatty liver, visceral fat, and abdominal obesity. And then phytochemicals are another thing which possess different anti-obesity properties. They reduce the body weight, visceral fat mass, plasma or leptin, and as well as the insulin levels in the fat reduce obese. Apples, oranges, citrus fruits, cherries, wheats, flax seeds, etc. These are all again rich in phytochemicals. And the last is the physical activity. We have already said that is equally important, that the 4th pillar of our lifestyle management. It increases people's total energy expenditure, which can help them to stay in energy balance and even lose weight as long as they don't eat more to compensate the extra calories by the birth. Physical activity decreases the fat around the waist and the total fat, and the weight lifting, push-ups, the muscle strength training, as even Rajeev sir highlighted. Cardio trainings ke saath muscle training. So the cardio doesn't mean you have to run on a treadmill. Cardio is as simple as going for a brisk walk. Muscle training again is not that you have to go in the gym. You have to basically do the strength exercises, which you can easily perform at home also. That burns your body burns throughout the day, even when you are. And if you do a good strength training, even when you are at rest, you are actually expending calories. You are actually burning calories from your. So you have to be very sure that 3 days in a week you should have some or the other kind of strength exercises. Physical activity also reduces depression and anxiety, and this will again cut down on the stress level.
Running short of
I'm trying with it, ma'am. So bottom line is, for weight, you have to control and aim the physical activity daily for an hour. Thank you very much.
Thank you so much all. Now we are moving to another session, the last session of the conference, that is related to respiratory and the relation with the obesity, the sleep apnea and obesity. And now we have a very eminent physician, Dr. G.C. Khilnani sir, to talk about this. And to chair the session, I would like to invite Dr. Tarun Ojha sir, Professor and Head, Department of Otolaryngology, Mahatma Gandhi Medical College and Hospital, Jaipur. Dr. Gaurav Malhotra, Senior Consultant Radiologist, Shri Balaji Action Medical College Institution, Delhi. Dr. Mahesh Mishra sir, Professor and Head Department of Respiratory Medicine, Mahatma Gandhi Medical College and Hospital. Dr. Deepak Gupta sir, Professor, Department of General Medicine, Mahatma Gandhi Medical College and Hospital. And Dr. Mohd Agrawal sir, Associate Professor, Department of Pulmonary Medicine, Mahatma Gandhi Medical College and Hospital. And Dr. Ramkishan Jat sir. I just request to the speakers, Dr. Mohd Agrawal sir, to introduce our speaker, Dr. G.C. Hilal sir.
Good afternoon, everyone. G.C. Hilal sir doesn't need any introduction because he's a well-known personality in our country, and he's the person who did work a lot in the field of sleep medicine, respiratory disease association with sleep medicine, pollution and respiratory diseases. So don't waste time. I start. He is chairman of PCR Institute of Pulmonary Critical Care and Sleep Medicine. Formerly he was professor in AIMS, Department of Pulmonary Critical Care Medicine. He has many affiliation, achievements and awards. He was overseas fellow critical care at Mount Sinai Medical School in USA. He was fellow and global governor of American College of Chest Physicians USA. And he has more than 250 publications in national and international journals. And he is also a member of WHO Technical Advisory Committee on Airway Pollution. So I request Klani sir to start his session.
Yes. Hello, am I audible?
Yes, sir.
Can you see us in
So,
audience?
first and foremost, good morning, good afternoon to all of you, and it's my privilege to be with you, for which I thank my senior, Dr. N Saxena, who was my senior as an MBA student as well as during MD time. And he always had affection for me, and of course my friend Dr. Mohd Kakkar, who we all studied together. And how I would have liked to be there and meet everybody, but unfortunately I could not be there. So I thank everybody for bearing with me and allowing to present my work virtually. So I hope my slides are visible before I start. So, ladies and gentlemen, obesity and sleep apnea. Why we are talking about it? You can see a person who is obese and just somnolent. And we were actually, when we were young, school children, somebody who is snoring, we used to say he is sleeping much better, he's in the deep sleep. And what I remember reading during my MD time was Pickwickian syndrome, obesity, hypoventilation syndrome. But as the science has progressed, we have realized that obesity along with causing hypertension, diabetes, CAD, osteoarthritis, and number of problems. But obesity and sleep is a big science. And I must say that it's not possible for me in this period of 25 minutes to cover everything about obesity and sleep, but I would be able to give you a bird's eye view. There is an obese person, wherever he sits, he just sleeps. There is another obese person who is quite alert, he is equally obese. So what is this? What is this relationship of obesity with sleep? So I would start with the basic changes which takes place in the respiratory system in obese people. And there is obesity. It leads to reduction in lung volume. As you can say, as a respiratory physician, I must talk about this first. There is reduction, the total lung capacity goes down, the functional residual capacity goes down, especially it is the expiratory residual volume which is goes down drastically. With that, the whole volume is reduced, and there are some mechanical effects which you must understand. The decrease in the diaphragmatic movement there is decrease in the lung compliance, there is decrease in the FRC. You can see a lot of fat in the, the chest wall. There's a fat below the diaphragm, and this leads to decrease in lung compliance, and there's increase in the lower airway resistance. And overall, there is an increase in the work of breathing, and which needs to be compensated by elevated drive in the respiratory centers and respiratory muscles. So these are the respiratory effects of, and what it leads to ultimately. It leads to obstructive sleep apnea, and I'll be spending majority of time on that. It also leads to obesity hypoventilation syndrome. So, can we divide sleep disordered breathing into obstructive sleep apnea and obesity hypoventilation syndrome? Yes and no. Because 90% of the patients who have obesity hypoventilation syndrome also have obstructive sleep apnea. But for the purpose of discussion, I would be dividing it into two. So what is a sleep apnea? Sleep apnea means the repetitive episodes of pause and respiration for more than 10 seconds, or for the duration associated with fragmentation of sleep, arousal, and most importantly, reduction in oxygen saturation. What is hypoapnea? Decrease in airflow to 50%, some people take it as 25%, which is associated with oxygen desaturation of 4% and or arousal, EEG arousal. So therefore, and if you both combine, that is called apnea hypoapnea, and that is the index that is used for narrating the severity. So sleep apnea can be obstructive, can be central, or what we call as OHS. We will not be discussing central sleep apnea, which is a neurological condition. Or as I said, it can be both. So what happens in the obesity? As I said, all obese persons do not have sleep apnea. Now this is a person who is obese, his BMI is 35, his AHI is 59. Apnea hypopnea index, because his tongue volume is too large. And this the yellow thing is the fat content in the tongue volume. The another person who is equally obese, the BMI of 35, but his AHI is only 9.6 and his tongue volume is less and the fat content is also less. And what happens in the obstructive sleep apnea? And I would like to draw your attention to this cartoon. In the normal breathing, there is a tongue, there is a soft palate, there is a uvula, and breathing is normal. Person breathes normally, exhales, and what happens during snoring? The sound comes only when the airway becomes narrow. You can see that this turbulent flow of air, which gives rise to snoring, and ultimately when the sleep becomes deep, the breathing completely stops. This is what is called as apnea and hypopnea. And that is what the mechanism of. And why in the obese patients? Of course, 70% of the patients who have obstructive sleep apnea are actually obese. So there is a increased fat deposition in the parapharyngeal fat. There is a diminished protective reflex that maintains airway patency. There is a fat deposition around abdomen, decreases lung volume, causing diminished oxygen store, and there is excess fat deposition in the upper trunk. And how common it is? Now, if your BMI is less than 25, the chances of having obstructive sleep apnea are less than 5%. If it is BMI is 25 to 29, which is called overweight, it is little more than 5%. However, if the BMI is more than 30, then there is almost 30% chance, both in males and females, that there will be obstructive sleep apnea, which can go up to 90% if the BMI is something like 45 and 50. In the pre-menopausal time, the incidence of OSA is much less in females as compared to males, but in the post-menopausal, like in cardiac diseases, it is the same. So about 70% of patients with OSA are obese. This is an Indian study. And prevalence of OSA in obese men and women is about 40%. Higher BMI is associated with high prevalence. So if the BMI is more than 30, 30% patients will have AHI of more than 5. If the BMI is more than 40, 98% will have AHI of more than 5, which is actually the number which is used for diagnosing OHA. So as the BMI increases, as I said in the ladies also, the BMI is 25 to 30 is 20%. There is another study which is shown. And if it is a BMI is more than 40, it goes up to 74%. So what are the risk factors? The main risk factor is of course BMI is more than 30. Next size, smaller size of 17 inches in males and 16 inches in females. As I said, it's relatively more common in males. Besides that, macroglossia, the tonsillar hypertrophy, nasal septal deviation, micrognathia, narrowing of the heart palate, and class 3/4 modified 3 or 4 Mullen-Patti score, which I will be showing. And there are some genetic disorders, endocrine disorders like hypothyroidism and alcohol, sedative and hypnotic use. Some of the majority of risk factors are modifiable. So what are the clinical consequences? Why it is important? As I said previously, we were thinking those who snore sleep better. Of course, they sleep well. But what are the consequences? These patients have snoring, there is witness apnea, there is nocturnal awakening. Sometimes they sit with the feeling of choking sensation and then go to sleep. They go frequently for urination and they always think that there is because of the prostate problem, but actually it's not because of prostate problem. Majority of time, nocturnal sweating, and most importantly, when they wake up in the morning, they don't feel fresh. You tell them you go for a walk. They say, doctor, I don't feel like. And then they want a cup of tea and coffee. There's a early morning grogginess and headache. And of course, the daytime somnolence is the most important. And in the United States, the most common cause of car accidents is actually sleep apnea. And there is decreased libido and impotence, and person is irritable, memory loss, and personality change. So there are several of these changes which and people live with it for ages. And of course, person sleeps wherever, person may cashier while counting notes, he may sleep. The wife or bed partner gets fed up with the, snoring. And as I said, the accidents are the most common. But that's not enough. There are metabolic consequences which are very important, which leads to reduced lifespan as well as. So if there is obesity, which leads to systemic inflammation, there is metabolic syndrome associated with, which includes hyperlipidemia and hyperglycemia, and there is systemic complication, which in the form of hypertension, left ventricular hypertrophy, endothelial dysfunction, atrial fibrillation, a very important association, and inflammation, and it leads to obesity, hypoventilation syndrome, pulmonary hypertension, and cause pulmonary. And ultimately, what it leads to is the atherosclerosis, ischemic heart disease, peripheral vascular disease, leading to high morbidity and as well as mortality. So not only the quality of life is affected, the span of life is also curtailed. So how do we diagnose? How do we suspect? I have already told you the symptoms. How do we diagnose obstructive sleep apnea? For the diagnosis, the history is most important. You have to take meticulous history. The cholesterol history of bed partner is extremely important. The history never complete without asking you ask about the snoring, loudness of snoring, you ask about witness choking, and that is only a bed partner can tell you. And of course, the sleep pattern that you have to ask. So how do we assess the daytime somnolence? There is the Epworth sleepy scale, which is the most commonly used. There are several other scales also. Sitting while eating, watching TV, sitting in the inactive player as passenger in the car, so on and so forth. They are scored from 0, 1, 2, 3. Patient does it. And a score of more than 10 is considered significant for daytime somnolence. If the score is more than 10, then you have to go further for the sleep study. Now, on the physical examination, the neck circumference, as I said, in males more than 70 and females more than 16 inches is important. The oral cavity, the tongue size, the presence of narrow arch palate, tonsillar enlargement, dystrognatha, micrognatha, and crowded oropharynx is important. Nasal septum deviation, colon turbinate, nasal polyps are all important. And Malampati score. Now, we who are practicing sleep medicine, we ask the person to open the mouth without asking him to say ah. And if you see something like this, the next thing you know that this person definitely snores and is very likely to have OSA. Similarly, this patient, and these are unlikely to be associated. So, Malampati score. But important thing is not the patient to say, as you do for ENT examination, just ask him to open the mouth. Among the investigations, you always do a lipid profile, sugar, thyroid scanning and all those things. As far as the sleep study is concerned, the laboratory-based sonography is what is recommended, but nowadays the people don't want to come to hospital because they want the comfort of sleeping in their own bed. So home sleep study is also important. It depends upon what level of study you want to do. So the polysomnography involves the EEG, it requires airflow, it requires ECG, it requires oxygen saturation, abdominal movement and chest wall movement. What happens in obstructive sleep apnea? You can see this is airflow has stopped. Okay, the airflow has stopped, this is apnea, but what is happening that thorax and abdominal muscles are working. So and this leads to sort of choking, it leads to sleep fragmentation, it leads to arousal. And arousals are measured by electroencephalogram, the airflow is measured by a sensor which is put in the nose, and this is measured by the leads which are put on the abdomen and this. And this is the main test, and you can do variety of studies. So how do we do the severity? If the AHI, that's apnea and hypopnea index, apnea means when the breathing stops for more than 10 seconds, hypopnea when the breathing flow becomes less than 50%, with desaturation of 4 or 4% or the arousal, we call it AHI. If the AHI is 5 to 15, it is mild. If it is 15 to 30, it can be moderate. If it is more than 30, it is severe. In practice, you would see a patient with AHI of 50 and 60. So in a short time, their breathing slows down for 50, 60 times, and that's what's severe. So how do I treat it? The management of OSA is a multi-pronged. It's not only giving a CPAP machine or surgery or dental appliances. I would be focusing on weight reduction. Extremely important. 1% change in weight is associated with 3% change in AHI. And OSA severity is reduced and in some patients abolished also. Unfortunately, in my practice, very few patients are able to attain that. But I know patients who have reduced 10, 15, 20 kilos of weight and sustained it. And they have got rid of obstructive sleep apnea and got rid of CPAP machines. But some patients can actually require bariatric surgery. And these patients generally have coexisting obesity hyperventilation syndrome, which I will be talking about. Pharmacotherapy, antidepressants, respiratory stimulants, CNS stimulants and hormones have been tried, but they do not significantly improve AHI or apnea index. In fact, if you give antidepressant, there are some sedative effects. They would actually enhance sleep apnea. Oxygen therapy is only used when desaturation is severe and usually it is associated with obstructive sleep apnea. Now this is the depiction of impact of weight loss. This is the 158 kg person with so much of fat and so much of narrowing of the airway. When reducing weight or after bariatric surgery, reduction in 50 kilos of weight loss, the BMI goes down to 29 and the fat goes down and the airway becomes straightened. So this is what happens when the benefit of weight loss. There are other measures which can be used for mild, like promoting sleep lateral position. Sometimes you tie a tennis ball at the back and so that person is unable to, the apnea is always more in supine position. So sleeping on the left lateral or right lateral, sometimes the role of raising the head of the bed, that's actually not very clear. There are ways of pharyngeal muscle stimulation, which is actually an area of research. I have never used it. But what is important is continuous positive air pressure. What is continuous positive air pressure? It's like giving a continuous pressure. It's a reverse of a vacuum pump in a way. You can also use bilevel positive pressure more for severe OSA and OHS. And you can also use auto titrating pad, what is called auto CPAP. That is, instead of giving a fixed pressure, the machine itself decides. This machine is more expensive, but the studies have shown that all fixed CPAP is better than auto CPAP. But to use fixed CPAP, you have to titrate it in the hospital where a person actually titrates to achieve an AHI of less than 5. Oral appliances can be used, but they are a little difficult to use, but dental surgeons are fond of it. There are mandible enhancement devices which can be applied in the night. So, CPAP remains the mainstay of treatment. It improves symptoms and quality of life and significantly decreases AHI. When we give CPAP machine to a person who has daytime somnolence, early morning drowsiness, the immediate benefit is that his sleep quality improves. He stops waking up in the night or going to the washroom. He gets up fresh in the morning. Daytime he thinks his life is different. He doesn't require much of tea and coffee and smoking to keep himself active. But that's not the only benefit. The CPAP has been shown to improve the blood pressure to some extent. And also there is some evidence that cardiovascular complications, atherosclerosis, heart attack and brain attack are also reduced. And of course it significantly decreases the AHI. Of course surgery, as you will be listening a full lecture, so I will not be talking about. There are nasal, palatal and tongue surgery and maxillary. These things will be discussed in detail, so I am not touching it. And these are the mandibular advancement devices for which I am not an expert. But it should be understood that dental appliances are useful only in mild to moderate OSA. They are never useful for severe OSA. So, I am coming to the next part of my deliberation, and that is obesity hypoventilation syndrome. And this is a picture that we are familiar with, the Pickwickian syndrome, which we are reading during our MBBS and MD time. The OHS, as I would call it, is defined as obesity, which is more than 30 kilograms per meter square, sleep disorder breathing, and most importantly is daytime hypercapnia. And this I must say, that is my still working as an intensivist in the ICU. Quite often patients come with acute type 2 respiratory failure and treated as COPD without realizing that actually they are suffering from obesity hypoventilation syndrome. There is sleep disorder breathing, and 90% of these cases have OSA also. And there is non-obstructive sleep hypoventilation. However, to diagnose this, you have to rule out COPD, ILD, chest wall diseases like hyposcoliosis, severe hypothyroidism, neuromuscular disease, and congenital hypoventilation. Don't jump to the diagnosis just because the person is obese and he has a rise in carbon dioxide. It carries a high morbidity and mortality. In fact, in 1 year time, 15% mortality is there because of the various reasons. So, the hallmark is hypoventilation, which leads to PaCO2 rise of more than 45, exclusion of other causes, and sleep disorder breathing is there, and then you call it an obesity hypoventilation syndrome. What is the pathophysiology? As I already discussed right at the outset, that there is obesity-related change in respiratory system, there is breathing abnormality during sleep, and most importantly, there is alteration in respiratory drive. And that is what leads to obesity hypoventilation syndrome. I would like to draw your attention to this particular graph. During sleep, now this is the airflow that you see. Now as the sleep becomes deep and person has OSA also, the airflow goes down. This leads to accumulation of carbon dioxide. But soon the breathing starts again with more vigorous force, as you can see. More vigorous force, it leads to CO2 elimination. Finally, when there is apnea for a longer time, it leads to CO2 accumulation, which is more. And over a period of time, there is a persistent CO2 elevation, which is a hallmark of obesity hypoventilation syndrome. What ultimately happens is that there is a decrease in response to carbon dioxide rise, and then which leads to slow rate of high carb excretion, leading to blunted respiratory drive and rise in CO2 and rise in the bicarbonate, and which becomes a surrogate marker of obesity hypoventilation syndrome. So, as you can see, if there is a short apnea, the CO2 does not rise. When the apnea is longer, the CO2 will go up, and this is the hallmark of obesity hypoventilation syndrome. So, the hallmark is why there is a blunted respiratory drive. There is a REM sleep hypoventilation. There is the obesity-related mechanical consent, which I have already described. There is a reduced central respiratory drive. Leptin, which is a powerful stimulant of ventilation. In OHS, there is central resistance to leptin because of obesity. And it has several other effects. This leads to deterioration of respiratory control, and which leads to daytime hypoventilation. So the ERS and American Thoracic Society and European Society have given definition. So both are actually same. The obesity, sleep disorder breathing, and daytime CO2 are more than 45, where you rule out other causes. How common is it? Obesity hypoventilation syndrome. If the BMI is 30 to 35, there is a 5% chance the person will have obesity hypoventilation syndrome. If it is 35 to 40, there is 10%. If the BMI is more than 40, 20%. So if the person has BMI of more than 20%, there is 20% chance. Why I am telling you this? That if you have a person who comes to you who has a BMI of 40 or 45, he doesn't have any symptoms. You have to ask him about sleep disorders, breathing, snoring and everything. Do a PCO, daytime ABG. There's very likely, there's 1 in 5 chance that you will find the CO2 would go high. If you don't want to do that, just do a bicarbonate estimation. If it is more than 27, then this patient requires a further investigation by doing an ABG and sleep study. So how do we diagnose obesity hypoventilation syndrome? Now this is the ATS document which see that if the CO2 is high, then it's very likely, this is recommendation 1A, that OHS is there. Now, if there is a lower moderate probability of OHS, then you do a bicarb. If the bicarb measures is high, you do PCO2. The bicarb cutoff when you are 27 was the only one in which a pooled analysis could be performed. So therefore, it's very important to suspect, it is very important to diagnose and treat. And finally, polysomnography is essential. 90% of these patients will have OSA along with that, and severe OSA is more commonly associated with OSA. So it goes both ways. If the person has severe OSA with the AHI of more than 30, think about obesity hypoventilation syndrome, and 10% patient may have hypoventilation also. So this is the REM sleep that you can see. There is absent flow, and the CO2 goes up and oxygen goes down. Here you can see the effect of obesity hypoventilation syndrome as well as the coexistence of obstructive sleep apnea, and you can see that CO2, oxygen goes down and CO2 starts rising to up to 60 and 70 in the night. It can be measured by end-tidal CO2, which can also be used by percutaneous measurement. Another thing, what happens during REM sleep, that there is a oxygen goes down, there is hypoventilation, and CO2 goes up. Oxygen goes down, CO2 goes up, which is associated with diminished respiratory drive. And this cartoon I showed you before also, this picture, there is apnea, and when the apnea goes for a longer time, there is a rise in the CO2. So, hypoapnea, OSA and OHA would generally coexist, and rising CO2 is demonstrated. Initially the CO2 is 21, 23, 38, 42, 45. It keeps on rising as the person goes into the deeper sleep, and this is a hallmark of OHS. Finally, how do I manage obesity hypoventilation syndrome, which is different from managing OSA? The goals of treatment is normalization of CO2 during wakefulness and sleep, elimination of desaturation during wakefulness, relief of symptoms, treatment of underlying OSA, improvement of sleep architecture and quality of life, prevention of complications including pulmonary hypertension and cor pulmonale. OSA is not associated with cor pulmonale, but OHS is associated with cor pulmonale as well as acute type 2 respiratory failure. People quite often first time land up in the ICU with type 2 respiratory failure with acute respiratory acidosis, and then we know that they are suffering from obesity hypoventilation syndrome. So the question in the young mind comes, do they all require BiPAP or non-invasive ventilation, or CPAP is sufficient, or we can use what is called AVAP, and I will be talking briefly about this. Weight reduction is of course important. Now OHS is one disease where bariatric surgery is very useful. If the BMI is more than 40 and you think that if this person is unable to reduce weight for whatever reason, is willingness or it failed, bariatric surgery needs a lot of improvement. Is there a role of drugs? Is there a role of tracheostomy? I will be talking briefly. So the positive area pressure therapy is important for managing OHS and OSA, and it is also useful for acutely decompensated OHS which present in type 2 respiratory failure and also in patients who fail CPAP therapy. Now, what are initially the ATS, American Thoracic Society, recommends that initial treatment of obesity hypoventilation syndrome is not BiPAP. The CPAP is sufficient in several studies. In fact, in the international conference, I confronted the best experts and why not BiPAP at the moment, at the outset. But they said that this is what the evidence says. So, these people have higher baseline AHI. There is a less restrictive physiology on PFP and less severe desaturation. So, initial treatment of OHS is CPAP. Now, some patients will fail CPAP. Some patients will come in acute type 2 respiratory failure. And CO2 will continue to be high with AHI, which will be high, and patient being symptomatic. There you use IPAP, and also that is you use bilevel positive pressure. And so how do you titrate? You keep on increasing. You start a low IPAP, and then you keep on increasing slowly. It should be increased every 5 minutes if the tidal volume is low. So when you are using a critical care ventilator machine where you measure the tidal volume also, so you start with the pressure support or what you call as BiPAP or NIV. Some people don't like to use BiPAP more when you use a critical care ventilator. You start with the smaller IPAP, smaller respiratory pressure, and look at the tidal volume. Till the time you reach tidal volume at about 6 milliliters per ideal body weight, and you should increase the pressure support. If the arterial PCO2 remains 10 millimeter high or more above the PCO2 goal, at the current setting of 10 minutes or more, an acceptable goal of PCO2 is a value less than equal to that. Suppose the person has awake CO2 of 45, you aim at 45, you don't try to bring it to 35. That's not a good thing to do. And pressure support may be increased if the SpO2 remains below 90% for 5 minutes or more. So therefore it requires a titration on the part of pulmonologist and intensivist when you are doing a NIV titration in patients with obesity hypoventilation syndrome. Now this is a study which is published in the Annals of Thoracic Society in the year 2020. This included a large number of patients where patients with OHS with or without OHS and compared PAP, the CPAP therapy. The age group is 45 to 74. PAP was delivered as NIV, most commonly bilevel positive pressure. Patients with both PAP and no PAP groups were typically given counseling with lifestyle modification. So we are running short of time. This is the last slide, last 3-4 slides. So there is the CO2 improved with PAP therapy. So all the parameters, awake hypoxemia improved, the AHI improved. You can see a distinct increase with PAP therapy. The quality of life improved, and daytime sleepiness also improved. So ATS recommendation says for stable ambulatory and diagnosis OHS, we should give treatment PAP therapy. And there is long-term follow-up also, whether you should give CPAP or BiPAP. The inference is the stable patient with OHS and COSA, NI and CPAP have similar long-term effectiveness. So therefore, the initially PAP and then you can try BiPAP. Now, AVAP is a average volume assured pressure support. This is a sort of advanced mode which gives assured volume and pressure. I have no time to go into this. As I already said, that bariatric intervention associated with robust outcome. So all patients with OHS who have more than BMI of more than 40 should be considered for bariatric surgery. Respiratory stimulant, majority progesterone, acetylcholine has been tried, but I would say they are of no value. And now this is a take-home message. Both OHA and OHS are associated with obesity, which is the theme of this conference. The best managed of OHA is CPAP, to my mind. Obesity, hypertension, diabetes, and sleep disorder breathing are associated with high morbidity and mortality. In fact, this has been included in the metabolic syndrome now. Awareness and high index of suspicion would lead to the diagnosis. Best screening of OHS is daytime PCO2 during ABG. When suspicion is low, screening can be done with bypass also. Majority of OHS patients can be treated with CPAP. Acute presentation of OHS should be treated with bilevel PAP therapy. Respected Chairman and ladies and gentlemen, I am really thankful to you for your kindness. Thank you. If there are any questions, I could answer it. I don't know whether it's feasible.
Any questions from the audience? Thank you, sir. Thank you for such a wonderful and enlightening us on obesity, hyperventilation syndrome, and OSS.
Thank you.
Thank you, sir.
Thank you so much, sir. And now we are moving to another lecture of the session and invite Dr. Rahul Modi and request to Dr. Tarun Ojha, sir, Professor and Head Department of Otolaryngology, Mahatma Gandhi Medical College, to introduce the speaker. Thank you.
Thank you. I welcome Dr. Rahul Modi on behalf of IMSACON, MGUMST and entire ENT fraternity of Rajasthan. He is a young, dynamic ENT and head neck surgeon and is currently working at the Dr. L.H. Hiranandani Hospital, Mumbai as a consultant in ENT and head neck surgery department. He is an alumnus of the renowned Massachusetts Eye and Ear Infirmary, Harvard Medical School, Boston, USA. He is a visiting faculty in the Division of Sleep Surgery, Stanford University, USA. Areas of special interest includes thyroid and parathyroid surgery and surgery for obstructive sleep apnea. He also has a number of national and international publications to his credit and currently the National Training Coordinator for the Indian Association of Surgeons for Sleep Apnea. Now it's over to Dr. Rahul Modi.
At the outset, let me thank Dr. Saxena sir for the kind invitation and Dr. Tarun Ojha for the opportunity. Always a pleasure. I keep on looking for excuses to come to Jaipur, wonderful city and great hospitality, and I've been part of the scientific program from today morning, hearing Dr. Gautam, hearing Dr. Gupta. It's been an eye-opener, great session. So without much ado, of course, Dr. Khilnani sir, an excellent talk on sleep apnea, and what I'm trying to suggest here is we need to think a little beyond about a problem that has kind of wide-ranging implications. So when we discuss about a medical condition, especially when we talk about sleep apnea, and I would say even obesity, there is a known. We know what is wrong, why it is bad, why we need to be treated, and then we know perhaps the areas where we need to research about. But believe me, 10 years in treating sleep apnea, I feel there is a 10x out there, the unknown, which we should realize with great humility our limitations and approach this subject. So, as was the case with COVID times, vitamin C became a popular anti-COVID medications. So such myths are attached with all parts of our medical fraternity. Sleep apnea is no different. Initial descriptions, like Dr. Khilnani said, was of the Pickwickian syndrome of Joe the fat boy who had snoring, obesity, daytime sleepiness, and that became the sort of brand ambassador for sleep apnea. So I see a lot of residents out here. Quick poll. How many patients with moderate to severe OSA complain of sleepiness? Quick poll. Can I have a show of hands for less than 50%? Can I have a show of hands for more than 50%? So it's a trick question, right? That's why you're asking the audience. So what does the data show us? That 65 articles studied over almost 25-year period showed only 46% of patients with moderate to severe PSG proven OSA had any excessive daytime sleepiness. And this will be your obese cardiac patient who will have a sudden MI in the night and who will never complain of daytime sleepiness, because even without excessive daytime sleepiness, they have a similar prevalence of cardiovascular conditions. So if your obese guy comes to you and you ask him, do you have sleepiness during the day? नींद आती है आपको रात को? नहीं जी, I am very fresh. And you will say नहीं sleep apnea नहीं होगा. You will miss half the population. Coming to number 2, and we are in an obesity conference, so I wanted to stress this point. More than half the population presenting to an academic sleep center in Boston, this was Danny Eckert's paper, were non-obese. So sleep apnea and obesity choli daman ka saath hai, but sleep apnea does not limit to obesity. Just the physicians in the audience, the doctors in the audience, the residents in the audience should home that point. I have patients thinner than me, I have doctors younger than me with classical sleep apnea with all the symptoms. So we come to that, and it's a common problem. Estimated 1 billion people. In some countries, the incidence of sleep apnea is more than 50%. There is going to be a paper going to be soon published by AIMS Bhopal, ICMR study, more than 5,000 patients studied with level 1 PSG data over a 5-year period, prevalence of 30%. Prevalence of 30%, and that is with comorbidities. Dr. Abhishek Goyal, the lead professor on that paper, told me that when he used the initial American criteria, the incidence was as high as 70%. So he said that nobody will accept that paper, so I had to make the filter even stronger, and even with that, he had a 30% prevalence, and these are your random population based, so it is something that we see every day for a condition which is synonymous with obesity, with drug-resistant hypertension, congestive cardiac failure, type 2 respiratory, type 2 diabetes, atrial fibrillation, and it will change when we start screening for it. Very simple, takes less than a minute. Just do this, stop, bang. It's not perfect, but I think it's a good start. So what does it tell you? That you just need 3 of this to be positive for high risk of sleep apnea to happen. So if you have a 50-year-old guy who's snoring, and a male, right? Male snorer more than 50. How many guys are like that? I mean, you don't need the guy to be overweight to be high risk for sleep apnea. Okay? So please keep this in mind. You have to screen more patients in the OPD. So I want to break this myth that OSA is only about sleepy obese individuals. You get kids, very common in kids too. So that about that. And when we do a good patient evaluation as taught in our medical colleges, we should do the same with OSA. Dr. Tsunami has highlighted some points. I'll just briefly summarize. First of all, you need to take the history properly. Stop bang, like I told you, more than 3 is a good outcome. Because a lot of time mild depression will also present in the same way. He will have sleepiness, he may snore in the night, may not feel fresh. You will put him on CPAP, he will not like it because there is underlying depression. So you need to take a good history. What is disease severity? Do the right sleep study. Home sleep study is very good for 90% of the patients that we see in the OPD. If your patient is having a comorbidity, if you are suspecting OHS, if you are having neurological issues, please order a full lab sleep study. But home sleep study is the workhorse for 90% of your garden variety OSA. And there are many modalities of treatment available in today's day and age. So don't just think about CPAP, and have a personalized routine. You cannot prescribe one diet to every person. You have to personalize diabetes therapy, you have to personalize blood pressure therapy. Sleep apnea also needs personalization. It cannot be a pressure mask to every guy who walks into the OPD. So poll question number 2. Now everybody knows it's a trick question, right? So AHI is the current indicator for severity. Now we say EDS is a hallmark of sleep apnea. Is AHI a good predictor of EDS? There are only two answers, yes and no. So now that I've told, it's a trick question. Any takers for yes? Okay, we have one brave soul. Any taker for no? Okay, so I've confused enough. So more than 800 patients, this is from Songtal's group in Singapore, and you have that AHI does not correlate with ESS. Okay, so we need to be very careful when we say iska severe HI hai, to severe EDS hoga. You may get guys with the mildest form of who have fallen asleep on the wheel and met with an accident. Young guys. So sleep apnea goes beyond AHI also. So what is sleep apnea essentially? Sleep apnea is a condition which is characterized by recurrent collapse of the pharyngeal airway during sleep, resulting in substantially reduced or complete cessation of breathing despite ongoing efforts. So you should have an obstruction happening in sleep resulting to a cessation of breathing, which is apnea. And why does the patient come to you? Patient will come to you because the wife is complaining or the husband is complaining. Patient will come to you with EDS, that I am not feeling fresh, I am a young guy, and the cardiologist will refer it to you that he's got an MI, he's got accelerated hypertension and all of that. You screen him for obesity. Patient will never come to you for increased AHI. Patient will never come to you because of some, desaturation metric. Patient will come to you with these symptoms. So when we design a treatment modality, we have to look for the standard modalities, which is CPAP, surgery or oral appliances. There is phenomenal role of weight loss in obese patients, positional therapy I'll allude to, and then there is the emerging role of drugs and myofunctional therapy coming to. So we know all PAP. I think it's a gold standard. I think the guy who discovered CPAP should be given a Nobel Puraskar. He deserves it. Simple for the patient who loves it. I'll tell you, he will be the most grateful patient to you. Within a week, he'll come back and say that, doc, I'm feeling 10 years younger. And he will more alert within a few days. He will have positive mood changes within weeks, optimal blood sugar control, decreased hypertension within months, and risk normalization. This is a life-changing event. All those senior doctors in the audience, हमें कभी मौका नहीं मिला, but to diagnose that undiagnosed hypothyroidism, 20 years back, and just to start him on Thyronorm and seeing him transform over a period of weeks was a very, kind of like a moment for us, satisfaction. Sleep apnea is such. You get a right patient on CPAP, he'll love you for his life. However, challenges come in maintaining them on CPAP. All benefits come as long as they use it and not. It is directly related to their adherence. If they are not using it, it doesn't help them. As simple as that. If the diabetic guy is not taking the OHA is not going to help him. If the blood pressure guy is not going to take his pills, it is not going to help him. And adherence to CPAP, this is 2023, fresh off the press, October paper. Treatment adherence is a key factor. वो व्यक्ति CPAP यूज नहीं कर रहा है तो हम कैसे उसका मदद करेंगे? And this is again age dependent. Okay, what studies have shows that within the first 90 days of trial, if you want insurance to reimburse CPAP cost in the US, they look at your usage data. If you are not using the CPAP, they will not give you a new mask. If you are not using CPAP, they will not provide you servicing of the machine. And what is the number between 18 to 30? 50%. 50% of the patients will not use CPAP, and the number is ranging between studies. If you see, imagine a 35-year-old, moderately obese, you tell him use a mask every day for the rest of your life. Unmarried girl, use a mask every day for your life. Possibly नहीं, आप बात नहीं कर सकते. And similar challenges faced with morbidly obese patient plan for bariatric surgery, and it is a very big problem in a newly diagnosed patient because there is too much happening in him. And why does the patient does not like CPAP? I am telling you it's a wonderful therapy, but can cause a lot of nasal congestion. If anybody is here used a CPAP, put on a mask, try using it. It's an air hose on your nose the whole night. You will get congestion, your allergies may worsen, you will be discomfort because the mask pressure is such, people get CPAP marks. People get necrosis of skin over the nasal bridges. claustrophobia, a lot of these sleep apnea patients have hidden depressions, they have hidden insomnia issues, hidden anxiety, and aerophagia, because there is a lot of air being pumped in the esophagus also, and dry eyes because of the leaks happening. So it's not an easy therapy for everyone. What we do is we give a trial. I give trial to every patient, every adult who comes to my clinic for 2 weeks to a month. If he is liking it, my life is simple. आप CPAP लीजिए, it's a best therapy, side effect free, आप use कीजिए. All patients receive, I'll talk about the myofunctional therapy. Only non-compliant patient is where surgery should be considered, and that is also a big if I've put in, they should have a favorable anatomy. And surgery, as we know, is a very good treatment for a static obstruction. Try to blow this stool away. You can't. You have to do surgery to move it apart to get a perfect airway. And that is where our evaluation comes in. That is where the role of the ENT surgeon comes in a non-compliant patient. You want to look for chronic sinus issues in that patient. If that person has got a compromised nasal anatomy, got a deviated septum, large turbinate, polyps, all that will become worse with the CPAP. He's got a bulky tongue, he's got enlarged tonsils and excessive fat depositions. So surgery can help support CPAP treatment also. In intolerant patient, one should have an identifiable obstruction, young patient, and no other significant comorbidities. So when we evaluate the airway, we just don't rely on sleep study. Sleep study is one of the metric. We are treating anatomy here. We are not treating physiology by doing surgery. Okay, that's a secondary effect. So I need to evaluate the airway. A fiber optic laryngoscope there in every ENT OPD can be done within 5 minutes. But the dilemma is where the obstruction happening, especially when the patient is sleeping in the night. Because when the patient is awake, he is not snoring. When the patient falls asleep, that is when the snoring happens. You need to evaluate the nose. Nose is the static part of the airway. It's a bony structure. It doesn't move. It's not a dynamic part of the airway. Very simple job for any second year resident of ENT to diagnose these things. So in ENT consult, especially if the patient is not comfortable with CPAP, is very important, and there is evidence. You correct his nose, 89% of patients who are not using CPAP will start using CPAP. So आपका compliance improve हो गया. Now when I have to evaluate the airway beyond the nose, I have multiple options. I do an awake fiber optic, but the patient is awake. I can do a Muller's maneuver where I ask the patient to create a collapse when he is awake. But the current gold standard is something called as a drug-induced sleep endoscopy. We create moderate sedation, image the airway, visualize the airway, look at the patterns of collapse, look at the sites of collapse and correct it. Sleep MRI has never become very popular because of obvious reasons. You make a person sleep in an MRI machine gantry for 20 minutes and try to extrapolate and try making someone sleep in the MRI for the first time, and some patients may sleep, but you may not get true data, so and it's not cost effective, not available everywhere, so it's not picked up very popular. Quickly, drug-induced sleep endoscopy, I told you, it allows careful selection of surgery. There is moderate sedation, mimicking sleep in a controlled setting, been around for about 30 years, became popular in the last, I would say, 15 years or so. Okay. So what we are doing nowadays is, so this is the patient setting, the surgeon is holding the scope, okay, there is the screen here, and we do parallel sleep monitoring, okay, this is optional, okay, but you can imagine, you can hear the patient snore, the patient is not sedated beyond, not for anesthesia purposes, he is mildly sedated in the OT, and you look at the patterns of the collapse that the patient is having, whether it is happening at the level of the velopharynx, whether it is happening at the level of the oropharynx, whether it is happening at the level of the tongue. And it doesn't take 15 to 20 minutes more than that. You need a very good anesthetist for this. And it's not that difficult. Interpretation is something that requires a little bit of an experience. So then we classify the patient as per the Mohd classification. We look at all the levels. Velum is the palatal level, oropharynx, tongue base and epiglottis. And we look at what's the direction of collapse. We grade the collapse as per the patterns and then we qualify the severity and we create kind of like a T&M staging, so to say, if you want to call it that way. Now, depending upon the collapse, we personalize the surgery. So if there is, say, partial closure of the airway, if you notice, then just doing a simple uvular palatal, these are very simple surgeries technically. These are not difficult surgeries, but you have to identify the right patient for it. If it's an anteroposterior collapse, you just need to suspend the palate forward. Now, this patient has a more severe collapse and there is complete closure happening. So you need to suspend more. You need to do something called as the expansion sphincter palatoplasty, and again, personalized therapy for the patient. And there are some red flags also. If the entire airway is collapsing, the guy is morbidly obese, then no amount of soft tissue surgery is going to help him. So we should all pick winners. I don't want a failure. I don't want to just do surgery for the sake of surgery. I want that satisfied patient to come and tell me, Doctor, maja aa gaya. So you need to be very careful. Going at the tongue base, we look for various types of collapse there too. And more importantly, lingual tonsil hypertrophy. That's a very easy, low-hanging fruit to correct and obstruct. And you should look for secondary epiglottic collapse if the tongue is obstructing the epiglottis. And you do this under BIS monitoring. So you maintain the level of sedation for that patient so that you get standardization. Agar aapne sedation level niche kiya, everything will start collapsing. If the patient is too away, then nothing will collapse. So you have to do standardization for that. You look at epiglottic collapse, it's not unusual to find someone like this who's got a complete epiglottic collapse and is not able to tolerate the CPAP. You do a partial epiglottomy, he will tolerate the CPAP very well. Or he may not have sleep apnea. Then skeletal surgery has a definite role, but it's a very morbid surgery and has to be selected where you can advance the maxilla and mandible. It's got a 2-year commitment in terms of orthodontia and all of that. And I think patient acceptability is still very low for this kind of invasive procedures in our country. So what does literature tell us? That if I operate, is every patient a success? Obviously not. So if I do an unselected surgery, my success rate will be as low as 30%. However, if I select the patient with the right anatomy, I get a success rate of 80%. As the anatomy becomes poor, my success rate will also drop. And if I get a really unfavorable patient, my success rate will be 1/10. So I need to be very careful in selecting the right patient. So which is the right patient? Or rather, which patient is the wrong patient? So we know about Friedman classification, part of the EAT curriculum. Anybody coming to your clinic, just make him open his mouth with the tongue inside. If you are seeing bulky tonsils, if you are seeing large tonsils, whatever may be the BMI, whatever may be the age, I have operated a 59-year-old, whatever may be the situation, you are going to get a fantastic outcome because you are removing a static obstruction out. If you get a situation like this where you are not able to see anything beyond bulky tongue, which is most of our obese patients, then you should not go ahead with surgery because if you remove the tonsils, the tongue base will start collapsing. You need to pick your patients well. And what is the message? If somebody is using CPAP only for 2 hours in the night, 3 days in a week, then the area under the curve is very little for it to show. It is a good treatment, but he has to use it. Even if surgery is able to get 80% of that, but it is every day. एक बार कर दिया काम तमाम. So हमें quantum of improvement बहुत ज़्यादा मिल रहा है. Even though it is not perfect, it is still better than using intermittent CPAP for 1 or 2 hours. What is the qualification for adherence? Minimum 4 hours a day or 4 hours a night, 4 days in a week. That means hardly 70% of the entire week you are telling the person to use CPAP and calling it a success. So usually if you get good reasonable outcome out of surgery, he is settled. So you need to pick your patients well. Myofunctional therapy, just exercises have shown to reduce AHI by 50%, improved sleepiness scores, improved oxygen levels, all the pranayam, all the Anulom Vilom, Kapalbhati, I think they knew something about sleep apnea more than we talk about it. And lastly, I'll just quickly mention, I know lunch is on the other side and I don't want to hold the audience much, pediatric sleep apnea. This is my passion project. Sleep apnea can be prevented if picked up in kids. We need to pick up kids who do mouth breathing, who have tonsils, who have adenoid issues and address them. They will have very common symptoms, some uncommonly known symptoms, grinding of sleep, sleep talking, restless sleep. They will have bedwetting. I have an 18-year-old who's still bedwetting because of mouth breathing and mild sleep apnea. decreased hearing because of serious and hyperactivity. ADHD is the term. You just give this nasal sprays to these patients, and within 3 months the mom will come and tell you, "मेरा बेटा साधु था, मुझे पता ही नहीं," because the kid is able to sleep better at night. And again, addressing some myths. Adenoids regress with age. I have enough 30-year-olds and 40-year-olds with adenoids. Okay, so not everybody they will regress with age. Surgery can only be performed after the age of 8, 10, 12 years. Classical teaching. Average age the kid gets surgery done. Average age in United States is 4 years. We can easily do a 2.5-year-old with less than 5 ml blood loss with today's instrumentation under vision. Recurrence is common. You have Cochrane database saying recurrence is even with the older technique 1 to 1.5%. And decreasing incidence. आजकल तो adenoid tonsil होता ही नहीं है. United States was doing 370 tonsil adenoid surgeries in 1996. Now it is doing close to double of that surgery within 10 years. Average age has gone younger. Finland and Belgium, where healthcare is completely free for everybody, is in 1200s and 1300s. Our number, national number, we don't have figure. I think Dr. Tarunoja will tell. I think we will be below 80 for the 1 lakh pediatric population that we have. So either हम बहुत समझदार हैं या ये वो बहुत बेवकूफ है. दोनों में से कोई एक चीज है. मतलब we are missing too many cases. Reason being is we were taught that wait till adenoid phases happen. And this adenoid phases guy is the one that is going to be prone for sleep apnea. We don't want this facial structure to develop. We don't want him to have a narrow maxilla and a narrow mandible. We don't want. You see a guy in the OPD sitting like this, and you just ask him whether you have nose block issues, whether he has snoring issues. I am telling you 110% he will be a mouth breather. He will never sit in front of you with lips closed. You will tell it is because of the iPad, it is because of the television screen, it is because of work from home, it is because of nothing. आप खाली हिस्ट्री लीजिए. He must be a snorer as a child. He may be having cold issue as a child, and he will always be able to keeping his lips. He may not breathe. He will always have a dry mouth, and that is his mouth adjusting to his airway, and he is getting abdominal posture. Surgery again with coblation is a very straightforward procedure. I was trying to show the surgery, but I think the computer has heard the audience. They are all agree. And finally, coming to the role of weight loss, yes, metabolic surgery has a big role. However, we need minimum of 7 to 11% of weight loss, whatever the route may be, to even repeat a sleep study. Greatest benefit are seen obviously with greatest weight loss and those with the most severe problem, and it will not resolve in all patients. So I have a lot of bariatric surgery surgeons who will stop the CPAP without doing a sleep study after their bariatric. उनका patient ने snoring बंद कर दिया. So मैंने बोला, can you stop insulin without checking blood sugars post-operatively? Can you stop OHS? You can't. So document a sleep study, document that there is no desaturation happening, and then think about stopping whatever intervention. Studies indicate not more than 40 to 50% complete resolution. There will be improvement in 80%, but 40 to 50% will still have significant residual sleep apnea, and you need to treat him like a regular non-obese guy. And lastly, if you identify positional sleep apnea, just make him sleep on the side. You will get a very good outcome. No CPAP, no surgery, nothing. But again, you have to personalize this therapy for the patient. This was a paper I got to write with one of my colleagues. He is actually incidentally Dr. Khilnani's student, Swapnil Mehta. So this is freely available online, and it is just like a 10-minute read designed for the busy practitioner to go through quickly and know what algorithm to follow while taking decisions during sleep apnea. Quickly, obesity and OSA, more than 90% overlap. CPAP is the gold standard, but surgery will be required for a big number of your patients and all of your kids with sleep apnea. And please do tailor-made personalized therapy, and just keep the eyes open. Just start seeing the posture, just doing stop bang, and we will not end up having a one-size-fits-all approach. We will be able to give custom-made therapies to all our patients. With that, I will thank the audience for being so patient, and you can open the house if there are any questions, if the hungry audience allows that, if the hungry stomach allows any questioning.
Sir is a diabetologist and a metabolic physician. He is a director and head for this C-Doc FMRI Gurgaon. Sir is also a faculty member diabetes certification course by British Medical Journal and Royal College of Physicians. He is a scope certified expert in obesity management. He is published 3 landmark review articles in Lancet. He is the author of 7 popular books on cardio-diabetes. He is a orator at many national conferences and seminars. He is a receiver of several prestigious national awards like Rashtriya Ratan Award and Arc of Excellence Medicare Award. May I now invite you, sir, for your lecture for the day.
Thank you, Chairperson, very much for your gracious and kind introduction. Pleasure to be in Jaipur, although I may be the odd man out. I'm from Gurgaon, but Jaipur has been a special place for me. I did my high school from Xavier's, Jaipur, 1976, and incidentally also got married to a lady of Jaipur, my wife. So Jaipur is not unknown to me, and it is always a pleasure to keep coming here. In fact, maybe next year we are planning again because our reunion of our batch is due. Anyway, so I will be focusing on looking beyond the glucose-centric approach. So they say diabetes के जो डॉक्टर होते हैं वो सिर्फ शुगर मेंटेन करते हैं, ऐसा नहीं. So we are in the midst of a global epidemic, and we know the components of that. I do not need to go through. But diabesity, 7 or 8 out of 10 people who are diabetic are also obese. And they are younger, they are maybe elderly, children, adolescents, and all over. And cardiovascular disease is rampant. So this is the prototype of the current scenario of obesity, the typical prototype of the urban Indian male. So there was a question during Rajeev Gupta's lecture on BMI. Should we use BMI alone? I think BMI is a very simple calculation, easy to do, but it is not enough because adiposity is a much more complex issue. There is a fat mass disease, there may be a sick fat, there may be a healthy fat, and it may have or may not have deranged metabolic and endocrine consequences. Again, this question, very simple to understand. Now these people are same height, same weight, same BMI. If you calculate only from height and weight, now who would be doubting that which is the healthier group? So height and weight has a limitation. Muscle mass, fat mass, lean mass, they may vary from person to person. So adiposity should be the focus of our attention in evaluating an obese individual, and we must rely on other parameters like waist circumference, hip circumference, waist-hip ratio, weight-height ratio, and of course assess the early-late weight gain related to IUGR, adolescent obesity, and later life. So type 2 diabetes is a disease of the adipocyte as much as it is a disease of the pancreas. This slide, some of you who have attended lectures, I wasn't here yesterday, but this is what we call the thin fat Indian. The thin fat Indian, it may sound two words are opposite, thin and fat, because Indians develop diabetes earlier. They develop diabetes at a lower body mass index. They have a thinner mid-arm circumference, but they have more fat, they have a higher waist-hip ratio, and they have a greater amount of insulin resistance. So as a race, Indians are disadvantaged in terms of visceral adiposity, and therefore Indian-specific or South Asian and Indian-specific guidelines and cutoffs for BMI have been recommended. Can anybody identify these people? So this is a slide which is a very old slide, and these two gentlemen are, this is called the YY paradox. So the person on the left side is Paul Yudkin, and the person on the right is Chittaranjan Yagnik. So why it is called YY? Their both names start with the letter Y. And they were healthy people, the same body mass index. And they happened to attend a conference in London where they did a plethysmography and were able to study their fat mass. See the body fat. Same BMI, a person who is from UK has a body fat of 9%, the person from India Mr. Yagnik, is 21% with the same body mass index. So, fallacy of body mass index alone. We need body composition, we don't need to know the adiposity. So, this is how visceral fat looks in an insulin sensitive and insulin resistant person. Lot of visceral fat around the organs responsible for dysfunctional adipocytes, production of pro-inflammatory cytokines, release of free fatty acids, and even atherosclerosis. And we know that obesity is a multifactorial disease. I don't need to elaborate this further because I'm sure during the course of these 2 days, this must have been spoken about. And I was very happy to be here earlier this morning to hear the lectures on nutrition and psychiatry, and of course Dr. Rajeev Gupta's lecture on cardiovascular effects. So there are factors which may be genetic, lifestyle, which may be related to psychology and our environment, and of course genetic and epigenetic factors. We all know the medical complications of obesity, and there was another question during Dr. Rajeev Gupta's lecture on when should we think that this obese person needs treatment and when should we say he does not. Now, if a person with a body mass index of 29 walks into my office and he says, I want to lose weight. I said, do you have diabetes, blood pressure? No, my lipids are normal. I have no diabetes. You have a family history? No. Do you do exercise? Yeah, I do 40 minutes of brisk walking. Why should you lose weight? Just maintain your weight, maintain a good lifestyle. He is not a candidate for weight loss surgery. He is not a candidate for weight loss drug. So there is according to the Lancet Obesity Commission, obesity is described as innocuous if there is no cardiorespiratory or metabolic or musculoskeletal consequence of overweight or obesity. And of course, somebody who is BMI 27 with diabetes, hypertension, premature CAD, smoker, family history, yes, he's the one we have to treat. So weight loss helps, and the degree of weight loss has different effects. If somebody can lose 5 to 10% of the weight, and this is, mind you, the maximum somebody can do with lifestyle alone. And we all know that the moment they give up that lifestyle, the weight comes back. People feel frustrated. Initial 5%, they're very happy. I did it in 3 months. Next 5%, very difficult. But there's some people will still do it who are highly motivated. After that, it won't. But what do you do with 5 to 10% weight loss? Diabetes is reduced. Cardiovascular risk factors, hypertension, dyslipidemia is removed. Lipid profile improves. Severity of sleep apnea. Yes, we have Dr. Modi just expressed. Severity of, that is the key. The AHI index will fall with weight loss. And of course, health-related quality of life, agility, alertness, musculoskeletal fitness, everything. So, more the weight loss, more the health benefits. Now, here comes the question. Bariatric surgery, 20-25% weight loss. Lifestyle modification, 5 to 10% weight loss. How do we get this 10 to 20%? That is where pharmacotherapy comes in. And when you start pharmacotherapy, you do not ignore lifestyle modification. No pharmacotherapy for weight management works without continuation of adequate dietary control and physical activity. It is not exclusive. So what it does in the concept of hyperglycemia, your beta cell function improves, liver's insulin sensitivity improves, adipose biology improves, intra-abdominal fat is reduced. One important thing in the practice of diabetes is that we always talk about HbA1c. Cardiologists talk of LV ejection fraction. You know, so diabetes is HbA1c. But actually, if you reduce the A1C to even 7, the magical figure, but the patient gains 6 kg weight gain. If If he gains 6 kg weight because of insulin and secretagogues and lack of physical activity, wrong eating, that is negated. So every 3 kg weight gain negates the benefit achieved of 1% A1C reduction. And we know that A1C reduction reduces microvascular complications. So it's a futile exercise, bringing the A1C down to 7 and then gaining the weight, because the other factors like hypertension, dyslipidemia and cardiovascular risk will go up. So talking of semaglutide, so this is a GLP-1 receptor analog and incidentally targets the multiple pathophysiological defects of type 2 diabetes. So we know that diabetes is related to the liver, pancreas, adipose tissue, so it increases insulin secretion, reduces glucagon, reduces gastric emptying. That is what creates the satiety. That is what some bariatric surgeons do the sleeve gastrectomy, because you reduce the stomach volume or you delay the stomach emptying, the satiety will come in earlier with lesser amount of eating. So that's the principle. And of course, the cardiovascular benefits I've already spoken of. This is the slide to understand what happens from birth to later in life. We start generally in our population, especially rural Indians now, they start with poor IUGR, poor maternal nutrition, low birth weight, then rapid catch-up of weight in adolescence, then ectopic fat deposition in vital organs like liver, pancreas, muscle, the expression of cytokines leading to endothelial dysfunction, the precursor of atherosclerosis, and leading to insulin resistance, the precursor of diabetes. So you end up with type 2 diabetes, dyslipidemia, and hypertension, and then ultimately the diabetes complications. So diabetes is treatable, but diabetes is also predictable and also preventable and also reversible. So we have to understand where to intervene. Now, improvement of maternal nutrition or improvement of child health, of course, there are a lot of healthcare authorities who have to deal with it, not adult physicians. So, and we know that if we only target A1C and let the weight go up and don't look after the blood pressure and lipids, we're not going to achieve much in terms of cardiovascular disease. You need a multi-pronged therapy, and this was very well exemplified in the Steno-2 trial, where these patients, besides glycemic control, were given good lifestyle advice, BP lowering, dyslipidemia control, aspirin, and this multi-pronged, multifactorial intervention really produced benefit. So now talking of semaglutide, so we call it, what is I told you the time frame in life. So obesity and adipocyte hypertrophy may start at a very young age. That is the time to intervene. So somebody has, obviously these are the musculoskeletal and the metabolic and the endocrine issues associated. Generally we wait for the hyperglycemia to become bad. When the A1C becomes 8, we tell now your chances of complications are increasing. But why can't we do it earlier? Why can't we treat younger patients? Why can't we treat people with risk factors? People with pre-diabetes? Why can't we prepone these lifestyle interventions? So this upstream approach, not waiting for hyperglycemia to set in and get uncontrolled, this will disrupt the pathophysiology of type 2 diabetes, may slow down the course and in some situations even cause a remission of diabetes, and therefore reduction in the microvascular and macrovascular complications. GLP-RA, I have told you, it works on the pancreas, it works on gastric emptying, cardiovascular risk factors. It has beneficial effects on the cardiovascular system. The one drug which, besides controlling hyperglycemia and hypertension, lipids and weight, has actually shown to reduce, Dr. Rajeev Gupta did mention the SELECT trial, where actually the trial which showed that semaglutide reduced cardiovascular mortality and therefore now obesity is talked of a cardiovascular risk factor. And probably the GLP-RAs like semaglutide, they work at multiple levels of the endothelium, reducing adhesion molecules, the expression of macrophages, the oxidation of LDL, and which ultimately leads to the plaque formation. There have been several trials, the pioneer series of trials. I'm not going to go into the detail, just to tell you that up to 3, 4, 5 kg weight loss can be seen with oral semaglutide. We generally start with 3 milligrams. Nausea may be an issue. Gradually over a period of time it can go up to 7 and 14. And some people do very well. Some people have the initial problem, they get over it. But you can aim at 5 kg weight loss. And HbA1c, of course, can go down by 1 or 1.5%. So it is worth it. Specifically with oral semaglutide, needless to say that higher proportion of patients will achieve the targets. And of course, the higher the dose, 7 and 14 is the right dose, but it is worth starting with 3 milligrams because we do not know how the patient is going to tolerate it. And nearly composite target of ideal A1C, a body weight loss of in excess of 5%, you can achieve in 40% people on oral semaglutide. And obviously, we have liraglutide for many years, we have dulaglutide, but the acceptance of oral semaglutide is much higher, and people are not ready to go into the injectable therapy till it is very necessary. So oral semaglutide reduced not only weight and HbA1c, which I showed you in the Pioneer series, it reduced blood pressure, and it also improved the lipid profile, LDL and triglycerides, and reduced CRP, a biomarker of vascular risk. Probably this is the reason why semaglutide has shown clear reduction in cardiovascular morbidity and mortality. So everything which is adverse for atherosclerosis improves with oral semaglutide. The major limitation is the initial nausea, and some people most people get over it. A small minority would never be able to tolerate it. We say, okay, give it up. So I'll just run through in the next 4 or 5 minutes of a case. How many of us are treating diabetes here? How many in clinics, in offices? How many of us are treating? Okay. So this is a hypothetical case. So he's a 46-year-old man, software engineer, a typical man who would come to Gurgaon in my office. So he's on medication, diabetic, mother had type 2 diabetes, father died of MI, he's married, he has a sedentary job, works 10-12 hours, eats irregular meals, and these are his indices. So A1C, BMI, blood pressure, nothing is good except urine, there is no microalbuminuria. Everything else is a little haywire. So he's initiated on metformin and diet, and then we just walk. We walk, and gradually drugs increase, we add more medicines, and the purpose is to prevent the complications. So 3 years later, now what has happened? So he was 46, he's 49, his A1C has gone up from 8.1 to 8.3. His habits have made it difficult to achieve life. So he did follow some lifestyle modification, but he did not reach this target of HbA1c. And now he started having symptoms of possible atherosclerotic cardiovascular disease. And we know that he had a family history of premature coronary disease in his father. So this is a comparison between the two parameters. So you see nothing is really working, drugs are being added. So now at 8.3, diabetes not controlled, had a MI, family history, not working. Now we think of giving a treatment. So we started on a GLP-RA and a statin. In any case, even a person with no cardiac disease, you can give a statin to a diabetic. That's a primary prevention. Aspirin is not for primary prevention in diabetes. Statin is used in almost all patients of diabetes. So GLP-RA, proven cardiovascular benefits. statin therapy was started at 3 years later, 8.3. And see what happened now. Now he's another 3 years above, 49 to 52, A1C comes down, weight comes down, blood pressure comes down, his microalbuminuria gets reversed. What more? So in hindsight, what we think is that whether we were right in waiting for things to deteriorate or we could have intervened earlier on. So if we have to manage the complications after they occur, that's not really the right thing to do. So had appropriate measures been taken early, probably we could have managed his cardiovascular risk profile better. And that upstream approach, we now know that would have been preferable. So just to summarize what I had to say, so we know the burden is huge and it is complicated by inadequate control, multiple comorbidities, and high body weight diabetes is a worldwide epidemic, or should we say a syndemic, and adopting an upstream approach towards weight management and type 2 diabetes will lead to multiple clinical benefits. So we have to be proactive. So we have to be really proactive and not wait for things to deteriorate. And strategies in weight reduction in their current scope have multiple challenges. Injectable, not acceptable to patients, bariatric, not acceptable. So this is a reasonable choice, right? And GLP-RAs have various overarching benefits beyond A1C reduction. A1C reduction with weight gain is not going to do any good for the cardiovascular risk. And these would have a valuable place in the upstream approach of diabetes. This is the hospital where I work, Fortis Gurgaon, not very far from Jaipur now, with good connectivity. So, and I must pay my tribute and gratitude to my chairperson and my mentor, Professor Anup Mishra, whom most of you would have heard in lectures and must have seen his articles in lay press and medical journals both. Thank you very much for your kind attention.
For the kind introduction. So the topic for today's talk is not related to obesity or the weight reduction. It's a bit different topic. Shingles prevention, time is now. Now it is the time when we should start thinking and acting upon by vaccinating our adult and elderly population and reducing the morbidity in this subgroup of population. Already they are having many comorbidities. So if the vaccines for specific diseases like shingles, pneumococcal, all these vaccines are available, so we should start thinking in this manner. So this is my disclaimer. A bit about the taxonomy of varicella zoster virus. It belongs to the herpes family. It is not same as the herpes simplex virus, although it belongs to the herpes family. It's a varicella zoster virus. The structure of this virus, why I am talking about this structure, because the most abundant glycoprotein expressed on the surface of PZB infected cells is the glycoprotein E, which is the main antigen used in this Shingrix vaccine. Now 99.5% of the adults more than 50 years of age are infected with varicella zoster virus and are at increased risk for this herpes zoster infection and the shingles. The primary infection is acquired mostly in the childhood. Then is the latent period, and this VZV virus becomes latent in the sensory ganglia nerves. Then if the patient in the elderly or adults, or if the patient is immunocompromised, there is reactivation of this infection. Up to 1 in 3 people will develop shingles in their lifetime due to this VZV reactivation. Presentation and risk factors for herpes zoster. Age and immunocompromising conditions are well-recognized risk factors. Decreased VZV specific cell-mediated immunity in these groups leads to this reactivation. Herpes zoster is characterized by acute pain and reduction in the quality of life, and it is predicted to continue increasing with the aging population, may also reflect an increase in other risk factors, more use of immunosuppressive agents, or likely there is more awareness and the diagnosis. So herpes zoster incidence is predicted to increase, presenting a growing burden in patients with comorbidities. Herpes zoster rash follows a unilateral distribution, this we all know, erupting in 1 to 3 adjacent dermatomes. The most common site is the thoracic, then is cranial and lumbar, then cervical, and last is sacral. These are the pictures of different dermatomes affected by this reactivation of herpes zoster. Now the immune system changes over an individual's life. At the extreme in the childhood or the elderly, the immunity of the patient or immunity of the people is low. It is the most immunocompetent ones are the adolescents and the adults. It gradually weakens with age, and a concept called immunosenescence is there, mostly after the age of 50 years. We will not be going into the details of this, the causes of immunosuppression. And after this 50 or 60 years, the risk of infectious diseases increases because of the diminished immune response. There is a need for vaccination programs that protect individuals throughout all ages of their life. Age-related decline in immunity and immunosuppression increases the risk of shingles. There is primary infection mostly in the childhood with this virus, and that develops specific cellular immunity in the adolescent and in the adult population. Because of subclinical infections, there is reactivation. So there is the immunity gets boosted, but not that to that limit as after the active varicella infection. After the age of 50 years, the VZB specific cellular immunity declines. Decline in cellular immunity is associated with an increased risk of herpes zoster. Talking about epidemiology, herpes zoster global data say that worldwide incidence is 3 to 5 per 1,000 person years. The risk of developing post-herpetic neuralgia in patients with herpes zoster is to the tune of 5 to 30%. And yes, there is risk of recurrence of herpes zoster as well to the tune of 1 to 6%. If we talk about our own Indian data, the incidence post 50 years of age is there's a very wide range, 15 to 81%. If we consider only 15%, then also it is an alarming figure, and the post-herpetic neuralgia is there in 10 to 54% of the patients who have been affected with herpes zoster infection. Comorbid conditions were frequently predisposing. Now there is a myth that only immunocompromised people acquire this, or there is reactivation of herpes zoster only in the immunocompromised people. Here in this study we can see that in all age group brackets, more number of patients who were immunocompetent acquired this herpes zoster infection. In the age bracket of 50 to 59 years, 91% of the people who had herpes zoster were immunocompetent, and only 9% were immunocompromised. Same is with other age brackets. So although the risk of herpes zoster is higher in immunocompromised people, the burden of disease is significant in otherwise healthy population also. Now what is the impact of shingles? Acute pain of herpes zoster is more severe than the pain of labor or post-operative pain. Similarly, the chronic pain which is there with post-herpetic neuralgia is more severe than the pain of arthritis, osteoarthritis or rheumatoid arthritis. Shingles is more than just a rash. It impacts the quality of life. It hampers the sleep. Sleep is disturbed. It hampers the enjoyment of life. Patient is unable to do general activities. There is low mood. normal work is also affected, relation with others is also affected, and there are also walking disabilities during the time of acute infection. So it affects physically, psychologically, socially as well as functionally. Shingles can lead to a spectrum of serious complications in patients. The neurological complications, although they are less than 1%, it may have, the patients might have encephalitis, aseptic meningitis, and many more. Similarly, the post-herpetic neuralgia is there in up to 30% of the patients affected with herpes zoster. Ophthalmic complications in the form of keratitis, scleritis, uveitis, and acute retinal necrosis is seen in 25% of these patients. And more severe complications in the form of stroke, TIA, myocardial infarction can be seen in up to 4% of the patients affected with this disorder. So a patient's risk of herpes zoster complication increases sharply after 50 years of age. Current treatment options are very limited. We can see the antivirals like oral acyclovir can reduce the herpes zoster severity and duration, but not the complications of herpes zoster. The patients of herpes zoster go from doctor to doctor, the ophthalmologist, neurologist, physicians, and they are never satisfied with the treatment. They keep on changing the medicines, tricyclic ones, topical agents, opioids, but only 14% of the patients with post-herpetic neuralgia are satisfied with the treatment. So who is at risk of shingles? The risk factor, one is female sex, family history of herpes zoster, stress is an important risk factor, COVID-19 infection, HIV, malignancies, autoimmune diseases, post-surgery, steroid use, cardiovascular diseases, COPD is very common risk factor along with asthma, and we all know about diabetes. There is more chances of developing herpes zoster in the diabetic population. So there are several studies which suggest that people with diabetes have an increased risk of herpes zoster and post-herpetic neuralgia. Diabetes is an independent risk factor for post-herpetic neuralgia. Increased healthcare resources usage following herpes zoster episodes indicate that herpes zoster is more severe in people with diabetes, and this may worsen the underlying sugar levels also. Shingles is associated with an increased risk of cerebrovascular and cardiovascular complications. There is an established risk factor for increasing the risk of stroke. If we talk about time, in the first month post herpes zoster, there are more chances of developing stroke, and it does not touch the risk does not touch the baseline even after 1 year of this herpes zoster infection. Likewise, if we talk about myocardial infarction, the risk of developing myocardial infarction post herpes zoster is maximum in the first week, and it touches the baseline after 12 weeks. COPD patients are at higher risk of herpes zoster relative to the non-COPD controls. If the patient is on oral corticosteroids, the hazard ratio is 3. It is even more common in patients. There are more chances of development of herpes zoster in patients on inhaled corticosteroids as well. And if the patient is not on corticosteroids, COPD patients, still there are more chances that the COPD patients have more likely to acquire this herpes zoster. It does not causes herpes zoster because a COPD patient, there is more number of the patients who acquire this herpes zoster. There are more number of hospitalization, more OPD visits, more drug use, longer hospital stay, and more sick leaves. COVID-19 is associated with an increased risk of shingles, herpes zoster, post-COVID diagnosis. If the patient is not hospitalized, there is 15% more chance of acquiring this infection. Similarly, if the patient is hospitalized, then the chances are much more, to the tune of 21%. Why? Because this infection may trigger reactivation of the latent varicella zoster virus. Corticosteroids used in patients are associated with an increased risk of herpes zoster. After a single dispensing of systemic corticosteroids, this single dispensing is a course of around 300 milligram. The chances of acquiring this infection is maximum in the first month, and it touches to the risk touches to baseline after 3 months. Now talking a bit about this vaccine, Shingrix was designed to induce strong and sustained immune response. There are two components, one is the antigen and second one is the adjuvant system ASO1B. This antigen glycoprotein A elicits a specific immune response against VZB. The primary target for this specific immune response is this glycoprotein E. And this adjuvant system enhances the immune response to the vaccine antigen. This is designed to induce strong and sustained anti-GE immune response. The unique combination of monophospholipid A and QS21 enhances both the antibody as well as the cell-mediated response. Adjuvant system is very important. It enhances the immune response to GE. This ASO1 induces a rapid and transient activation of the innate immune system, and the early and transient response is followed by a high and durable VZV specific response. Here in this graph, we can see that the comparison between the non-adjuvanted and the adjuvanted formulation. With the adjuvanted one, there is a stronger, broader immune response, and that too is very durable. Now, two main clinical trials, one was Zoe 50 and second was Zoe 70. These were designed to study this, the efficacy and safety of this Shingrix vaccine. Primary objective for Zoe 50 was herpes zoster efficacy in person more than 50 years, and primary objective in pooled analysis was post-herpetic neuralgia in more than 70 years and SZ efficacy in more than 70 years. While with Zoe 70, it was all these things were studied only in the more than 70-year age bracket. Here we can see that Shingrix delivered more than 90% efficacy against the shingles in patients more than 50 years of age. Whatever is the age bracket, the response is more than, it's around 96 to 97% in both the studies. If we talk about the risk of post-herpetic neuralgia and other complications, there is significant reduction in the complications and post-herpetic neuralgia in both the studies to the tune of 91% in the more than 50-year age group with post-herpetic neuralgia and 93% in other complications. So by preventing shingles, Shingrix decreases the risk of post-herpetic neuralgia as well as other complications. Now this vaccine has now been studied for almost 10 years, and it has been seen that even after 10 years there is no waning of the immunity. 89% efficacy against shingles is seen even after the 10 years study. Adverse reactions are not that significant. There is mild to moderate local adverse reactions, so it is very important. The safety has to be the priority when we are going for any kind of vaccination. So we have to educate the patient that there will be only minimal infections, local adverse reactions reported up to 7 days post-vaccination. Mainly it was pain, redness and swelling, that too lasted less than 3 days. Similarly, the systemic adverse reactions were fatigue, fever, gastrointestinal adverse effects, headache, myalgia and shivering, that too lasted less than 2 days. So it is a very safe vaccine. Safety results were support the favorable benefit risk profile of Shingrix in subjects more than 50 years. Here we can see that these adverse reactions were comparable to placebo. In different population with different comorbidities, it was found to be same efficacy was found to be same, and as well the safety profile was also same. Efficacy against herpes zoster, we can see in all age groups it is more than 96%. In the age group more than 70 years, as per the pooled analysis, it was to the tune of 91 to 92%. So talking a bit about hematologic malignancies, post hoc analysis revealed a vaccine efficacy of 87.2% against herpes zoster in the immunocompromised population as well, and the adverse reactions were almost same as in the immunocompetent ones. Similarly, hematopoietic stem cell transplant recipients, there was a protection of 68.2%. With solid tumors, the results were almost the same. With renal transplant, there was a protection of 80.2% at month 2 and 66.7% at month 13. HIV infected subjects, there was a significant humoral and cell-mediated response post-vaccination. Yes, sir. This is the summary of the immunocompromised population. Approvals, almost 50% have approved this vaccine. India has approved this vaccine early this year. Recommendation, most of the bodies around the world have recommended the use of this vaccine. The CDC, Gold guidelines related to autoimmune diseases, guidelines related to immunocompromised patients, cancer guidelines, solid organ guidelines. So the time of administration, Shingrix is given as a 2-dose series. Primary vaccination schedule consists of initial dose followed by a second dose 2 months later. There is a flexibility of second dose from 2 to 6 months. Waiting period post development herpes zoster is, as per Canada guidelines, it is 1 year. CDC allows post the resolution of the acute stage. Immunosuppressive patients, yes, it has to be given 2 weeks prior to the initiation of any therapy, chemotherapy, and if the patient is to be prescribed rituximab, it is to be required for more than 5 months after the last dose. It can be co-administered along with other vaccines supplied in 2 vials. It is to be reconstituted, intramuscular injection, do not freeze, it is to be kept at the temperature of 2 to 8 degrees. To summarize, 1 in 3 people will develop shingles in their lifetime. Herpes zoster impacts the patient's quality of life, more than 90% efficacy across age groups above 50 years. There is sustained vaccine efficacy to the tune of 89% over 10 years, and also there is a established safety profile. Thank you.
Well, thank you everybody for being here on this Sunday afternoon. The 2 days that we have had intense deliberations on obesity, of course an occasional lecture on shingles and artificial intelligence. But it's been a wonderful 2 days of knowledge, of learning, of discussions, and I must thank all our speakers and the audience for having stayed back and learned and talked about so many things.